Eh? Welcome, Bhavanta. Hello, Balu. Balu,
Sir, good
I
afternoon,
think.
sir.
Well, good afternoon, Balu. Nice joining.
Thank you, sir.
One by one, all experts are getting into the line. Very nice. Yeah.
So what are you going to demonstrate, sir, today?
Today, Dr. Rajmandian is going to demonstrate anti-resection.
Okay.
See a rectum, and they will introduce the about the case. Then we will going to start.
Okay, sir.
Varghese, welcome, Varghese.
Good afternoon, Varghese, sir.
Yeah.
Hi, Bhavanta.
Yeah. Bhavanta, welcome.
Hello,
Hi,
Dr.
hi,
Ravish.
very nice.
Welcome, sir. Hello. Hi.
Yeah.
Very nice to see you.
Yeah.
And
Hello, sir.
Yeah. Friends, I think now it is
Can you hear
almost
me?
ready. Yeah, I'm getting your voice. Yeah. Hello. Hello.
Yes, sir.
Huh? Okay.
your voice is
Friends,
not clear.
this is the second episode.
Anyway.
Friends, I welcome all of you to this second episode of GEM Televersity CME program, and which includes a single theme concept, live videos, panel discussion, and lectures, everything. And based monthly once program, we do it. And this month is for colorectal, and we have chosen the rectal cancer today for this live surgery. And also we have talks from GEM Hospital, each different topics, radiology, these different aspects. I think when we talk about with experts like you all, there are different India as well as from Sri Lanka and different parts. Our experts are today taking part as a panel, and they're going to moderate during the live surgery also, subsequent lectures. And the delegates, whatever they are, send a question, and it will be answered now and then by the experts as well as the faculty. And today, Dr. Rajmandian, we all know, he is a colorectal surgeon and wide experience in performing a C-rectum, particularly ultra-low rectal resections and sphincter saving. He has done a large volumes and has created a good result. Today, he has made a trocars, everything ready, going to start. So that way, I welcome all the delegates and faculty, every one of you. And on behalf of GEM Hospital, our sincere appreciation to be part of this. And every month, one program is going to be, and the next month program will be announced soon at the end of this program. And now we are going to start the live transmission, live CA rectum, and I'll hand over to Rajbandian to talk to you, and you can interact on live. Yeah, and case is going to come now before Rajbandian starts, and I think we start with the case presentation.
Good afternoon, sir. Presenting the brief case capsule. 45-year gentleman presented with complaint of altered bowel habits and mucus discharge per rectum since 3 months. History of loss of appetite and loss of weight present. No other significant history. Family history not significant. General examination within normal limit, systemic examination within normal limit, per abdomen soft, non-tender. On PR, circumferential ulceroproliferative growth felt at around 5 to 6 centimeter from anal verge. On lab parameters, hemoglobin 11.2 at the time of presentation, total count 9,730, urea creat within normal limit, CEA 1.9, LFT within normal limits. Sigmoidoscopy, suggestive of circumferential proliferative growth starting at 5 centimeter, extending up to 11 centimeter. Biopsy taken, suggestive of moderately differentiated adenocarcinoma. CT scan of abdomen and chest, suggestive of circumferential thickening in upper and middle third of rectum with severe luminal narrowing, periserosal fat stranding, and perirectal lymphadenopathy. No distant mets noted. MRI pelvis, suggestive of irregular T2 intermediate circumferential wall thickening in mid and lower extension into mesorectal fat along the anterior and left lateral aspects with nil CRM abutting the peritoneal reflection cranially. Stage T4A, multiple enlarged lymph nodes in the mesorectum and both internal iliac region noted. Diagnosis: locally advanced carcinoma, lower rectum, T4A, N2, M0. After a multidisciplinary tumor board discussion, patient was planned for long course neoadjuvant chemoradiotherapy plus interval chemotherapy, 3 cycles of capox, and followed by surgery. Patient received 50 gray with concurrent capecitabine followed by 3 cycles of interval chemotherapy, capox. Post neoadjuvant chemoradiotherapy MRI suggestive of polypoidal circumferential wall thickening in the upper, mid, and lower rectum, extension into mesorectal fat along the anterior and left lateral aspects, with CRM involved at 3 o'clock position, abutting the peritoneal reflection cranially, stage YT3, N1B, MR tumor regression grade 3, moderate response. Areas of T2 hyperintense signal within the distal aspect of wall thickening in the mid and lower rectum, likely post treatment changes with residual lesion. Significant decrease in size and number of the mesorectal nodes, decrease in left internal iliac node. Patient was posted for lapular with diversion ileostomy.
Good afternoon, everybody. Good afternoon, everybody. This is Dr. Raj Pandey from GEM Hospital. I once again thank you all the moderators. I hope everybody can hear me. Dr. Pradeep, Dr. Anil, Dr. Bhavanta, Dr. Varkis, Dr. Roshan, and Balu. Thanks for joining and moderating the session. I think all of you would have heard about the history. So just I have made a port. Before going inside, I will show the port from outside. Are you seeing? Okay. Okay. This is the standard port placement.
Hi, good afternoon,
Yes,
Dr. Raj. Anil here. We can't see the
Yeah.
external view.
Can you see the external view now?
Yeah, now we can see. Yeah,
This
now
is
we
the
can see.
standard port placement for my ultra-low anti-resection. Can you see? This is my para-umbilical. This is my camera port. And this is the suprapubic 10 mm port. Mostly I will be using all the clips through this and stapler as well. And this is the initial right hand working port in the right iliac fossa. And in between the camera and the right hand working port, there is another 5 mm is there for the retraction. And you can see my in the left iliac fossa or left lumbar region, another as a left hand working port, and another one you can have in the epigastrium. So initially I will be using this. This is having a long bowel holding for the left hand working. Then this will be a retraction, and these two are a retracting port initially. So this is my standard port. So initially I will be working with this. So slowly I will be changing all these circumferential whenever working for the left colon mobilization and sphenic flexor mobilization. I will be using this as a left hand, and this will be my right hand working port. And patient, you can see patient in head down and left up position. And particularly this, you should make sure that the patient has been fully strapped. There should not be any problem because you'll have a steep head down and left up as well. And my assistant is Dr. Nitin and Dr. Rajiv. And the staff nurse is Sumadi and Sandhya. And anesthetist is Dr. Kiran and Prabhakaran. So you for doing ultra anti-section, you should have a good experienced supportive staff. Otherwise, you can't finish in time. So that's why I made the ports just before. So one thing is any surgeon, once you go inside, since it is ultra low, it is around 5 to 6 centimeters from anal verge. Suck. So you don't think you will be seeing the tumor once you put the scope. You can see. So you can see this is the tumor. Probably it is a little bit peritoneal infiltration is there. That's why they said T4A. So post MRI, sorry, post neoadjuvant CT at MRI after 8 weeks, I think 8 to 10 weeks, there is not much response to the tumor, and it is a mucin separating. This patient has received 3 cycles of interval chemo as well. So in spite of it, there is less than 50% regression of the tumor. So that's why we plan to go for a resection. Hope it should
Raj,
come. Yes,
Raj,
question. Yes.
Can you ask your audiovisual people to just do the mirror image, because it's coming, right is looking as left and left is looking as right.
I will ask Pasupati.
Now
I mean, okay. I mean, in the
Raj,
in the video, you're asking about the video or external
no,
view?
video also.
Video
Both
also.
yeah.
Okay,
Yeah.
they are working out that. Okay, just give a hook.
Raj, the pre-operative MRI had shown
Yes,
internal
yes,
eye. Like
yes,
any
yes. I am
plans
not
of
planning
doing
for this. Post neoadjuvant, post RT, that a second MRI, it shows there is a significant recurrence of internal node, and it was less than 3 mm. So we are not planning to do a lateral lymph node dissection for this case.
Uh,
So your cutoff is 5 millimeters or 7 millimeters?
My
Or
adoption
if-
post RT, if it is more than 7 mm, I will go. So what I have done
Rajpan,
before, yes,
sir, is
one
the epigastric port standard for all of your LAR, or is it only for ultra low, sir, the epigastric port?
mostly because that is the port which is going to help you for your sphenic flexure mobilization. Most of my AR will be with the sphenic flexure mobilization. Just I want to show you something, because this is the way I used to do. Before that, you can see I have clipped the IMV. So initially I have clipped, and I have made a way where we are going for after the IMA ligation. Can you see? So I have just mobilized the IMV pedicle, and I have just clipped it. I didn't divide it, so that after that, after the IMA, that I will continue to have in the same plane. Okay. So now I have retracted. So this is the sacral promontory. From there, I will be opening the retroperitoneum. My incision will be going. You can see this will be the nerve. So only while going down, you should have a bit careful. Give me the hook. Then just I'm going to use my hoop initially, but usually all the thing I will be using harmonic. தள்ளி அப்படியே இருக்கட்டும், தள்ளி இங்கே இருக்கட்டும். நான் கரெக்டாக வைங்க. இல்லை அப்படியே இருக்கட்டும். அப்படியே இருக்கு, அது இருக்கட்டும். Just for opening the peritoneum. So once you open the
Dr.
peritoneum,
Raj?
yes, sir. So I could not see you. I can hear you. Is it Dr. Pradeep?
Yes, yes.
Good afternoon, sir. Nice
afternoon.
to.
Yeah.
Thank you for joining with us. I'll see them.
Welcome. And I just have a
Yes.
question. If suppose you have access to a 2D system and a 3D system,
Okay.
what's the preference while doing LAR?
I mean, for the laparoscopic, or you are talking about
Laparoscopy. Laparoscopy.
laparoscopic now? So initially, before 4K, we were doing in the 3D. That 3D was not that
Yeah.
much good, but now 3D system they have improved. So once the 4K has
Correct.
come, I am very comfortable with the 4K. Probably in future it will be
Okay.
coming the 8K is on the row, I feel.
Okay.
But very rarely we'll do. Probably Dr. Polyvel used to do 3D even laparoscopically once in a while, because
Okay.
we have the system. But I am
Okay.
very comfortable with the 4K.
Okay. 2D 4K.
Yes,
You
2D
mean
4K.
to say? Yeah. Okay. And what would be your indication of putting in a pre-operative ureteric catheters?
Yeah, preoperative ureteric catheter. Mostly, if there is a loss of fat plane between the bladder and the ureter, then I will go for. If there is associated sigmoid diverticulitis with this thing, then I will go for. So just last week we did a case diverticular perforation with the malignancy. So I have to put a ureteric stent, then start.
Right.
So would you prefer a ureteric stent or ICG? Because
No,
nowadays I think
yeah. I was just waiting, Anil. So I prefer a stent rather than the. Probably I will. I think I showed that video. So even if ICJ, you could not see where the ICJ is going. So whole tumor and everything is formed a perforated phlegmon mass. Even the ICJ would not be seen there. So what I feel, I prefer to do have a stent. Even if you have injured, then immediately you can repair.
No, but there have been instances where the ureter has been cut even with the stent. So if I think if you put ICG only in the
Not all
ureter,
the time. That yes.
yeah.
Many people are saying that, particularly the gynecologist, they said if you put the stent, the pliability will not be. So you have more intent to do injure the ureter. But if you are in correct plane, unless there is change in the pathology, very unlikely to injure. But if you have a stent or the catheter, if you injure also, immediately you can repair it. Otherwise, without stent, if you injure and if you have to repair, that will be very difficult to put the catheter inside. That is a problem.
So this fibrosis that you are seeing, do you think that it is because of this induction chemotherapy that you have given, interval chemotherapy? Is it more common with that?
No. Because of the radiotherapy, chemotherapy, yes, little bit is there, but post neoadjuvant CT, all my cases are post neoadjuvant CTRT. But still, but it depends upon the patient to patient. But all the patients will have more interstitial edema will be there, fluid will be more. So while you are dissecting, you will have fluid. While particularly you are going to the pelvis, more frequently you may have to put a suction.
What? So mostly, I think
Sir,
when
in
the
this
time interval
imaging, there was a
between
threatened
radiation
CRM
and
at 3 o'clock. At what level exactly was it, sir?
Sorry, what ball? I could not hear you. What you are telling.
go ahead, Dr. Varghese, go ahead.
Uh, Sir, SRT,
Yes,
sir,
ball.
in
Yes.
this MRI, there was an CRM which was threatened at 3 o'clock
Yes,
position.
CRM
At which
threatened. That's
level
why I'm
from the
telling.
elevator
That
was
is,
it? And what is your
3
plan on
o'clock.
that, sir?
Yeah. This, see, you can see I was showing there is a CRM threatened there in 3 o'clock, they said. Probably you can see here, where unlikely the ureter will be going like this above. So in ultra low, it's a very unlikely. Anyway, I have told even before starting, I have told our urologist anytime we may ask you to put a stent. But here I am not thinking of any ureter injury for this case so far.
Dr. Raj Pandyan, I'm Bhavanta from Sri Lanka. Very nice
Yes,
discussion.
Bhavanta.
Hi.
Nice to see you.
Yeah, nice to see you. Are you planning to do a high ligation here or low
Yes.
ligation?
High ligation.
What is high ligation? Okay.
Yes. நீ நல்லா பிடிக்கணுமா?
So, Dr. Raj, any tips to preserve the nerves at this point for the young guys who are?
Yes.
When you are going to take the IMA.
பிடிச்சுக்கோ. So you maintain the presacral fascia. So if you maintain the presacral fascia, so I made the incision from the sacral promontory along the medial border of the aorta near the middle of the bifurcation. See, already I have made an incision where it has to go. Can you see that? So I will be connecting like this, sister, left hand.
Yes. So that's a wonderful demonstration.
So we have to include all the lymphofatty tissue in this area.
At the same time, you're not breaching the endopelvic fascia as can be seen clearly, because once you go below that, then the nerves are at risk.
Yes.
It should be between the mesorectal fat and the endopelvic.
And the presacral fascia or endopelvic fascia.
Beautiful.
I have talked to him.
Will you look for the left ureter at this stage, or will you
No.
not at this stage?
You will be seeing.
ஹலோ
ட்ராக்ஷன் கொஞ்சம் வேணும்.
இல்ல போயிட்டு வந்துட்டியா இல்லையான்னு கேட்டேன்.
சாரோட பசுபதி எங்க இருக்கு? அங்க போய் ஆன் பண்ணு. இல்ல சாரோட அடிச்சிடும். ரைட் டவுன். அப்படியே.
Dr. Rajavandiam?
Yes, sir.
Yeah, my audio, there is some problem now, sorted out.
Yeah, I can hear you now.
Yeah, the cases where the nerve is not demonstrable, like what you did now, what are the tips to avoid injury to the nerve?
Yeah, that is, you don't open the presacral fascia so that you will not go near the nerve at all. Okay. So all my patient, so many, we have done more than 1,000 cases I have done now. So we have very, very minimal, probably 3 cases they have to go with the prolonged catheterization for 2 months or 3 months, that's all. So I have 2 ureter injury for so far, which I have managed on table itself.
But if there is a thick mesorectum, the nerve is not demonstrable. Where exactly?
Yeah. You need not go and demonstrate the nerve. You keep the
where
plane.
exactly you will be opening the first.
Same way. This is the standard way of doing. This is not. This fellow is a moderate built male patient. I feel there will be difficulty while I am dissecting only in the deeper pelvis where the CRM is involved. I feel. And as Balu has told, there is a CRM positive. That area I should be careful. If requires, I may use the stenting, but I feel I may not. Right.
You always prefer to use the harmonic as an energy source? Or?
Yes. But you should be very careful. So once I have injured the IMA at the base, and it has avulsed from aorta while I am demonstrating case. I think Balu was assisting me. He was helping to in that case.
Dr. Rajavandiam, like when it comes to origin of the IMV,
yes,
mesenteric artery, then one side you have to clear the lymph nodes, the other side you have to protect the nerves. So how do you balance between two?
See, when you come close to the IMA at its origin, usually all the sympathetic plexus will be going close to the aorta and it will be close to the origin of the IMA. So you come from above, and sometimes there will be a tenting effect. You just analyze whether it's only just attachment fibrosis or the nerve.
Yeah,
if you feel something, yes, this tenting effect, then leave that. This will be the nerve.
So that nerve has to be dissected down, isn't it?
Yeah, no, don't touch. You need not dissect the nerve. You just leave that. You do not go down. Only above it, you just so that you can push it down, rather than dissecting the nerve.
Dr. Raj, do you always do like this, that you first take the vein and then the artery?
Yes, initially when I've recently last few years I'm doing like this.
Any reason for that? Because when you clip the vein, the specimen is going to be congested and turgid, and there will be.
Initially I thought, but it is not happening like that.
Okay.
It was not. So it is easy actually. So we will not miss the plane. even if there is a small bleed while you are dissecting, you can
Okay.
miss the plane. That's what I felt.
Okay.
So next is I was just looking for the this is the artery. Left up.
What's your opinion, Dr. Ajbandam, between
Yes.
high ligation and low ligation?
So all the onco surgeons prefer high ligation. All the non-onco surgeons prefer low ligation. But once you know the anatomy, I go for the high ligation because I feel you can give a complete oncology clearance. But the literature says there is no difference even in the oncology clearance also if you do low ligation. And they
Right.
prefer the recently they said it is the leak rate or the ischemic part of the proximal bowel is less if you are doing for a low ligation.
Right.
That is the theory, but I have not come across same thing so far. We have been doing high ligation, but what is the mean of high ligation, low ligation? After the left colic, you leave the office. That is the usually that is the low ligation. High ligation means you include the left colic. So even before the origin of the left colic, you go. I feel I have to take this, otherwise I will not go.
Is that a nerve?
No. Yeah.
It is doesn't look like.
That
Looks
looks
like
like
a
the
nerve.
nerve.
Yeah.
No, no. Most of the time it looks like
If
nerve.
you
The nerves will not come like this. Actually, you can see so much of IMA is left behind. Okay.
So,
See,
but
these are the.
irrespective of the oncological clearance, if you are trying to do an ultra low anterior resection, I think all of us will definitely do a high ligation to enable a good reach to the pelvis. Isn't that
Yeah.
a practical way we do it, sir? So, if it is an
They
ultra low,
say, but I feel if you are dividing the IMV
yes.
at the inferior border of the pancreas, then this thing should leach actually. But as you said, you have to divide the ascending branch of the left colic vessel. Otherwise, it will not reach.
But in Indian
and
patients
all
where the sigmoid is redundant, I think it is
No, 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 no,
more
no, no. That
easier.
is no. That is wrong concept. So once you are removing the IMVA, then the blood supply to the sigmoid is gone.
No,
So
no,
you
in
have
low,
to.
low ligation.
So you
so
can't
always
keep the sigmoid.
always if you do a high ligation, always you should mobilize the splenic flexion and
Yeah,
bring it
yeah.
down, isn't
I
it?
feel for
Otherwise, there'll be a
all
ischemic segment.
low anti-resection, you have to do a splenic flexion mobilization. Otherwise, all the problem will come.
Yeah, I would
So
agree
sigmoid,
completely. I think
yeah,
even if
yeah.
tend to overspeed
Sigmoid
the long.
redundant is not a this thing. That is not a correct.
No, no, not for
So
the. But I say that in low ligation, that it's possible to reach far more down than a Western patient comparatively. Compare our patients to the Western patient, it is more possible to reach down
But
because there is a more length of the sigmoid form. You don't agree with that?
But when we are doing a low ligation, also we are taking down the sigmoidal
yeah, yeah,
branches
yeah.
and leaving only the left colic. So the sigmoid will still be of a compromised vascularity. So
No,
the
very,
length of the
very.
sigmoid, as Dr. SRP was saying, may not really be a factor because the ischemia will be a factor when I have ligated it close to the left colic.
Very low ligation, agree that you have to go for a high ligation. Very low anastomosis, you have to go for a high ligation. But then I'm talking about where, not that low, ultra low, this thing, anterior section. Those cases, I think that the low ligation works as well as that of a high ligation.
Right, sir.
There has also been some evidence that if you preserve the left colic, then your chances of an anastomotic leak are lesser.
Yeah, that is true.
Can you see one? There is a parietic lymph node is there. So I have to
Yeah,
take
yeah,
that.
yeah.
So
We can see that.
yeah. So these are all the fibers attachment. These are all not nerves.
So what are your tips to identify and drop the nerves, especially if the case does not have much desmoplasia, sir? So how can a beginner identify the nerves and drop
You,
the
you have to be
nerves?
yeah. You have to drop the nerve. So you should go very slowly. Don't be in a hurry. So use judicially. So while you are handling the this thing, you are very close to the aorta and the origin of the. This is probably the IMA para-aortic lymph node. So while doing this lymph node excision, you should be careful. You may have, you can see the lymphatic tissue. Okay.
Dr. Rajabandan,
Yes.
do you come across IMA to be single branch other than more than one branch from aorta?
Usually IMA 95-98% that will be single only. Sometimes you will have a double. Probably the sigmoid will be arising along with IMA, or the left colic will be arising along with IMA. That you can see. But usually I will be deciding like that. As you said, in an obese patient, if you can't go beyond that, then we'll do like this. Mostly I will try to dissect in such a way that you can put one hemolog or one clip, then it will be okay.
No, but if there are two vessels, so you will be dividing both vessels.
Yes, you have to divide. That you have to be very careful. Sometimes that meandering mesenteric vessel will be there. That will be the that is very difficult to identify, particularly old patient, atherosclerosis, some features of features of aortic aneurysm. In that case, usually IMA would have been thrombosed. So these are the patients should be careful. Okay. So I'm going to say. So beyond that only this thing.
So now your plan is to go for a inferior mesenteric vein.
Inferior mesenteric vein already I have ligated. I am just I didn't divide it.
Okay.
I am just removing all the lymphatic tissues and the lymph nodes at the root of the IMA and near the para-aortic region.
Can you show us the duodenum as well, just for trainees maybe watching it? Because duodenum is next to that, isn't it? Yeah.
This is the DJ flexure.
Yeah. Okay.
Can you see? Yes.
Yeah, correct. Yeah.
எப்படிமா இது யார் இது பிடிச்சிருக்கு எப்படி பிடிச்சிக்கோ ரொம்ப தூக்கூடாது மெதுவா ரொம்ப தூக்கூடாது சக்ஷன் கூட
Raj, would you take down the IMV at this time or
no. IMV will not be taken down now. It will be at the end only. That is
so some people do take down the IMV
no. IMV you should not take now. You can clip and keep, because I will tell while I am doing the surgery. You will know how it is going to help.
Actually, if you take IMV, small bowel also can fall down. You have some apron effect, isn't it?
Yes, exactly.
Yeah.
See, you will have a tenting effect for you to the surgery properly.
Anyways, would you put a Goskins there in there where the small bowel is? Would you sometimes put that?
So only area
Not in this patient, but
no. Actually, I will be using Goskins suck. See, one area I will be using Goskins. Once I do the dissection, then I will use the Goskins. Now I am just concentrating IMA pedicle only. Just I want
anyway,
to do.
Dr. Rajmani, you have nicely
IMA.
packed the small bowel, and that's a
Yeah.
Nicely packed the small bowel. You can't see the small bowel in any part of your dissection, so that's a great thing. I think.
That is because of the low and left up and low. The head down and the left up position. Ligation. Section code purchase.
Do you like to put a gauze piece, Dr. Raj?
Yeah, suck. Harmonic. Ligation.
Sir, when you're doing a high ligation, even when it is a high ligation, how much of a IMA stem would you be comfortable leaving so that we don't end up in mishaps? Sir? So, what is the standard
Wow.
practice or the recommendation by you? At what level should an IMA be clipped and divided in a high ligation, sir?
Usually, at least 1 centimeter you have to avoid. That's what I was just telling. If it IMA has got avals from the aorta, then you have to stitch in the aorta, or you have to stitch in the clip in the aorta only. Clean. Section kodu. Pudichu. Idu kuduma. Femolac. So now we have see the IMA pedicle nicely. Suck. So I'm just putting a hemolock, one hemolock. Protein clip. Protein clip. பெரிய clip கொடுக்குது.
So if we may sum up, for a standard anterior resection, low ligation may be good enough, and the IMV can be taken close to the IMA itself. But if you're doing an ultra low anterior resection, at least for technical reasons, a high ligation and the IMV being taken close to the inferior border of pancreas. So that will be a standard technical practice, sir. Is that okay to tell to our junior colleagues who are seeing?
Okay. See, for the standard, you can do a low ligation. Then for the ultra low, you want to do what? So, see, if you are doing the high ligation, you can see the lymph node dissection very adequately. Probably the surgeon feels, okay, we have done a good lymphadenectomy. For any malignancy, particularly if it is in the upper rectum or rectosigmoid, you have to do, because it is very close. The lower third rectum, you can do a low ligation, I feel, because you not have that much. But I feel for all the anterior section, you have to do the high ligation if you have a proper oncological lymphadenectomy. Not much difference if you do a high ligation or low ligation. Once you get practice, you feel high ligation better than the low ligation, because multiple clips you have to use. You can use a single clip, and nicely you can have the plane clearly. All these things are important. Ingiva. Is it okay? Everybody agreed? What Bhavanta, Dr. Shank, Pradeep?
Yeah,
Yes.
fantastic dissection. Yeah.
No. For the answer questions they were asking,
Yeah.
I'm just
Yes,
telling my view.
literature is still not very
Yeah.
equivocal about
Yes,
whether
yes,
high
yes, yes,
ligation
yes.
or low ligation, what is advantageous. So I think till that is not clear, I think we have to do according to the situation. And usually 1 to 2 centimeter of IMA will help us to preserve the nerves.
Yeah, I would also agree with that. So
Yes,
basically,
sir.
if you preserve 1 to 2 centimeters of
So
the
now,
vessel, then
now,
the
Harman.
yeah.
So now people are asking about the. I think Anil was asking about. Will you see the left ureter? Can you see the left ureter?
Yes.
So I didn't.
Yeah, yeah.
I am. Yeah.
Nice.
Usually,
Nice.
I am not bothered about the nerves and the ureter if I am in the correct plane. Only in the if I am clear in the presacral fascia and the white line of talls, so you can see it will be preserved. Unless the pathology warrants you, there is some tumor is there adherent here, then you should take your own. See,
The problem also comes if the
last week case, as Anil was telling, whether ICG or the tumor perforated, it is a rectosigma tumor with the diverticular perforation, and it was all adherent here. I could not go. So from anteriorly, it was all adherent here, and the dome of this bladder as well. I could not see anything at all. So even ICG, it may not help. You have to visualize. So I put a stent, then medial to lateral, then I went to this plane. So protecting the ureter. Then I blindly go from the lateral, thinking that once you preserve the ureter here, very unlikely from lateral to come and injure, because automatically you'll be seeing the fascia.
right.
So that's we have come to the lateral aspect.
Dr. Rajabandhan,
Yes, sir.
yeah, regarding that ICG demonstration, you have to put in a ureteric catheter and
Yes,
then
yes. You have to put a ureteric catheter and you have to inject the ICG inside the ureter,
now
not through the
recently,
IV.
This the striker people were saying that
Uh,
there the new dye is coming up that is going to be excreted through the kidney. Any idea
then it is
about
a
that?
good. I have no idea, but it will be good then. You just give through the IV and it is excreting, then it is nice. You need not depend on a urologist to do that.
Anybody has any information on that?
Idu kuduma. So I am okay. So with this tenting effect, I have just done a medial to lateral resection. So before I am dividing the IMA. So after dividing, you can see, then
I understand this patient has received a long course.
yeah, long course RT, man.
Yeah. What is your choice? Whether you use always a long
Always
course or
long
short
course.
course?
Say
Okay.
where I will use short course. So if I am planning to do without chemotherapy, old frail patient, but I want to sterilize that area to go for ultra low, then I will give only short course, then take up for surgery. Patient is not fit for a chemotherapy. So such cases because if you are planning for ultra low anti-radiation, what I felt is my experience. It is better to sterilize the area. So we will not be micro perfect all surgeon to go and do the surgery in the ISR, intersphincteric resection or ultra low air. So if you sterilize that area, I feel the local recurrence has very much reduced.
What about delayed short course? Like after
Yeah,
short course,
always short course also. I'm telling only delayed only. So what we practice always, even short course also, we wait for 6 to 8 weeks before, because all our patients, they could not tolerate the RT effect.
in fact, it has got a very excellent results. Waiting
Yes,
for
yes, yes.
6 to 8 weeks.
Yes, yes, yes. Even before that, that New Zealand, I think the paper from New Zealand came. But even before that, whatever short course we were doing only 6 to 8 weeks after short course.
So do
So
you give?
Rajpanyan, Bhavanta here. After long course, how long you wait?
Same 8 weeks, 8 to 10 weeks. So during waiting period, we'll give interval chemotherapy 3 cycle. And this patient, since it's a mucinous, not much the response. Initially, I thought we want to do a TNT for this patient because T4A, ugly tumor, EME positive, lateral lymph nodes, harmonic. But he is not responding. He was, I feel, only the partial response. You should not wait, young fellow. The tumor will be aggressive. Better to remove before it progress to metastasis.
Dr. Rajabandam, for delayed short course, do you combine with the chemo?
Some cases, yes. Post-operatively, yes, but
No,
not all the cases. If it's old
pre-op.
patient, pre-op. Pre-op was so
Pre-op.
far only few cases I have done initially, but now any patient going for a neoadjuvant CT, I go for a long course only, not short course. You can see the white line of TALT. So now, so you can see there will be a tributary for the IMV. So you have to go beyond this. Then only you will have this proper. இது புரியுமா? Long போட்டுருமா? Long அது.
Raj, any difference between short course and long course when you dissect any planes are altered or something?
See,
What do you
that is
say?
the say. That's what they say. After
Yeah.
giving short course, you do within 7 to 10 days surgery. But
Yeah.
our what I have one patient with a short course. I think that's not from our. This from the North India. I think from West Bengal. So when they came for surgery, I said patient is not at all fit. So then we wait for another 4 to 6 weeks. So our patient could not tolerate the short course, and you should not touch the patient on radiotherapy effect has not yet gone. The muscle mass effect in Asians or Indian patient is less when compared to the European patient or American patients. So the radiotherapy, the effect of the radiotherapy will depend upon the muscle mass and the fat mass. See, percentage of muscle mass is less in our patients, whereas the fat portion is more. Whereas in European patient or Americans, they have more muscle mass than the fat, equal like 70 or 80 kg patients. So that's why what I feel, I used to tell our oncologist, don't prescribe the same dose what they are giving in the USA, and because our patient could not tolerate. So many toxicity has occurred because of the overdose, which you couldn't predict. So we don't do any level of the drug level in the blood. Only after patient developed all the complication, then we could not save the patient. So few patients we lost because of the toxicity of the chemotherapy post-operatively. And pre-operatively, few patient may not be made into able to make a fit for the surgery also because of the toxicity.
Just for the young guys who are watching, I think the differentiation between gerotas and the mesocolon is well seen here. If you can just point out, Dr. Rajpandian,
Yes, yes.
if you can just
So
point out.
I am just working only the Tolls fascia, which is covering the geratus fat. So I'm just doing the medial to lateral mobilization. So still that I will not divide the IMV. At the last only I will be dividing.
And going so far medial to lateral is also another important tip, because a lot of times there is a tendency to just go laterally.
After that you lost the plane. And particularly this patient is not that much obese. You should not have much fat. So you should be careful and see. But doing that, you should not jeopardize the blood supply to the left colon as well, because now you have divided the IMA at its root. So you have to depend on the marginal vessel.
All the fat should remain on the colon side.
Yes, yes.
Nice dissection, Raju.
Very nice. Very
Thank you,
nice.
thank you, sir.
Nowadays, there are these systems which distinguish between the fat of the colon and the kidney. Do you
Yes,
think
yes.
that it adds any
Yeah,
value?
yeah. This is yeah. So if it is clear fat, it is Geratas vescia. If it is ugly, dirty fat, it will be there.
There are some systems now. I think the Olympus, which has yellow filter, which gives a little bit of yellowish coloring to the Gerotas, yellowish green.
That may be useful while you are doing the sphenic flexion mobilization to differentiate between the fat and the pancreas.
Absolutely.
Sometimes obese, fatty person, it will be very difficult to differentiate the pancreas and the fat.
Yeah, and also this yellow enhancement feature also helps to differentiate fat from the lymph nodes when you are doing lateral pelvic lymph node dissection.
I've also found that feature useful when you are dissecting around the rectum.
Yeah.
Because sometimes otherwise, while you are cutting the fat, the energy source can touch the rectum. So that's a useful feature there also. Wonderful dissection.
So this, you take a little bit more time for dissecting this medial to lateral, so that while coming from lateral to medial, it will be easy actually. So I take my own time. It should not be in a hurry.
What is your superior extent of mobilization in a case like ultra-low, sir? Will you delineate the entire lower border pancreas, or you have a glimpse of the spleen and stop? So where will you stop superiorly after you have taken the IMV, sir?
So I will be, after taking down the IMA or IMV. Still, I have not finished.
IMV.
Anterior border of the pancreas up to the sphenic sphenic hilum, I will be dissecting now. And so after that, I will be keeping one small gauze piece to identify while I am coming from lateral to medial, to identify that place. So here is the only place where I used to have a gauze piece. Okay, gauze piece to go. So maximum I have done. I think little bit more I need, but okay, I will come from medial to lateral. So this is a very thin fascia, white line of toes fascia. Still you can see. Even small bleed you should not allow. Otherwise, it will mess your plane. Now you can see. You see the psoas muscle now. This is the Geratas fascia. Put it. Put it. Go. Gas piece no chukapa. Balu, what is the question you have said? Over the whole inferior border of the pancreas, up to the neck, actually, it has to be divided.
That's what, sir. So
Will be
if you're
showing
doing
at
an
the
ultra
yes,
low anterior dissection, what will be
whether
the
doing ultra low or low anterior section, both are same only. So because unless you do, it will not come. Not partially. If you do, it will not come partially. So there will be a tension in the proximal colon.
So I just wanted to bring out the message that the inferior border pancreas has to be delineated and everything has to be separated when you do a complete mobilization. That's all.
So now I am just already you have seen the inferior border of the pancreas. I did. So now I am trying to dissect medial to lateral up to the sphenic hilum. So anyway, maximum now I will be keeping a gas piece here. So while coming lateral to medial, it will be easy. Okay. Can you see the inferior border of the pancreas?
Yes.
Very, very
Hello?
obvious.
Yes, yes, yes. So once you see that, then it is okay. That spleen is seen. Keep a gas piece here so that it will be easy while you are coming from lateral to medial. Kuduma. Pudi. Pudi. So you have to dissect quite a long.
So regarding splenic flexure mobilization, which is your preferred approach? Is it medial to
So
lateral or
sphenic flexure
lateral to medial,
mobilization.
or is it a combination?
Yeah, always sphenic flexure mobilization. There is no single step actually. It will be a combination. So now we have already mobilized the sphenic flexure mostly from medial to lateral, then lateral to medial, then the Lester sac approach. All the three combinations you have to apply. You can't use only one like lateral to medial. In that case, it will be difficult. You may go in a wrong plane also. So always sphenic flexure mobilization is a combination of medial to lateral to medial, and the Lester sac approach. So now I think I will keep a gas piece there, then I will go down. So I'm going to keep a gas piece to identify it while I am opening the Lester sac, that we are not injuring the mesocolon. This is the area I will keep. So this is the only area where I used a gas piece, usually on all my laparoscopic surgery. I think gas piece suction. Very, very rarely I use gas piece. Suck. Okay, so now we are going to lateral to medial. Still, I am not gone beyond this thing. This is the tumor. You can see. We'll see. Hopefully, it should coming. So I will go a little bit in the. Suction podadala. Suck. Because of the neoadjuvant chemotherapy, you can see I was telling the interstitial fluid will be more. Good.
In this particular patient, how many weeks we have waited, sir? What is the earliest you operate and what is the comfortable zone
Earliest I operate
on
usually
the
8
longest
weeks.
side?
So earliest I used to operate 8 weeks. This patient had waited for 10 weeks. I think 11th week this.
Dr. Rajbandit?
Yes, sir.
If there is a complete pathological response, in which all situations you would consider that to avoid the surgery, like old age?
So in low rectal cancer, that is within 4 to 5 centimeters from anal verge, and there is a complete clinical and radiological response after TNT, then I will use to have a wait and watch policy such patient. But
No,
still,
all patients,
sorry?
all patients or only selected group?
No. Most of all patients who are have good response. But particularly if it is a young patient, then I want to have very close follow-up. So now recently I have a patient I wait and watch for 1.5 years. Later she developed a lesion. I mean, then I did a local this thing and it became as positive. Then I did a intersphincteric resection for that patient. So in my now already 4 patients are waiting like that after complete response. But the problem is how you are going to assess it. That is the main thing. If you are not satisfied by doing the sigmoidoscopy endoscopically and MRI and TRUS, and if I suspect, then I'll do any uptake in the PET scan, then I'll go directly for surgery. And any operable case, nicely operable, then we can preserve the sphincter, then I will go for surgery. Purima?
So in young patients, you feel it is justified?
No, young patients should be very careful because it will be aggressive and it will reappear. Because most of the time nowadays our APR rate is becoming nearly very. So last year we have done only 2 or 3 APR only. So mostly we are preserving the sphincter.
I think wait and watch policy is something that you should discuss very well with the patient.
Yes, very well with the patient as well as in the tumor board.
Intensive follow-up.
If they are not a good patient for follow-up,
because
then it will be very difficult. You may miss the patient.
Yeah, in our part of the world, I think the patient might get lost, and we should have strict follow-up criteria.
Another thing is many patients after neoadjuvant CT, they feel they are comfortable. Why you want to do a major surgery? So one patient, young female, so like 3 years before. So I opted for surgery. I given the date after neoadjuvant CT. She felt very comfortable. Nothing was there. Why you want to undergo? She didn't come. After 1 year, she came I was asked to see the patient in the emergency. She came with the locally advanced rectovaginal fistula.
Generally, in our part of the world, they generally think when you
only
say
diversion.
Response,
In
our part of the world, when you say you have a complete response, they generally think that it has been cured, so they don't come up for follow-up.
They will not come.
Yeah.
Most of the patients like that only.
Old age, absolutely no concern because
Yes.
But when it comes to younger patients, only we justified in doing that. So you say only depending on the radiological findings, so you go for biopsies?
No. I will go for biopsy as well. So if you have a doubt, then I will go for biopsy.
I think there are set criteria for what is a complete response.
There are very standard criteria of endoscopy plus radiological imaging and a PR. Usually
clinical imaging and endoscopy, all three.
All three.
Yeah, all the 3 is there. But in spite of this, there are some patients they have lost. I mean, they have a recurrence. So in the standard criteria, there is no any role for the biopsy. They said don't do a biopsy, and there is no role for a PET MRI or PET CT actually.
Right.
So now slowly we should include that also in that criteria so that stringently we have to see the patient, because there's not much time for the recurrence to occur or the patient develops distant metastasis. I think
the follow-up is very rigorous. Every 4 monthly MRI plus.
No, every 3 months. Initial year every 3 months. Even some they say and second year you can go for 4 months. But
as
every
per
for initially
the
every month you have to do PR and sigmoidoscopy. பிடிச்சுக்கோ இது எடுத்துரு பிடிச்சது விடுமா அது லாங் போட்டதில் அது எடு அது எடு இது அதுதான் லாங்கு தானே அது இதில் லாங் போடு இது எப்படி இது
And while doing
So I'm just
endoscopy,
continuing the hold this அதில் போடுமா.
when one is doing a endoscopy, one has to do a narrow band imaging also of the suspicious area.
Yes. That is now standard in all cases. இருமா இப்படி first இப்படி
when you're doing this step, Dr. Rajpandian, have you changed your ports or are you still using the
No. Same port. Only thing I'm just changing my right and left hand working port. So now I have put my right hand working in the suprapubic area.
Can you show the external view of
பிடிச்சுக்கோமா external view காமிங்கம்மா.
if you can show a PIP?
It's PIP is working.
Not very clear. If you can reverse the image.
Yeah.
அப்படிக்கா come out.
Again, the splenic flexure mobilization, is it mandatory in all cases or depending upon the situation you decide?
No. In my all LAR I used to do the splenic flexor mobilization. Unless I am doing only sigmoid colectomy for a benign condition.
Raj, you said you are working through the right hand in a suprapubic. Would you think it will reach up to the splenic flexure?
Mostly, but not all the time. Then I will be changing my right hand to the left lumbar port. That's why I told initially.
Okay.
Maximum I will try to do here. You can see. So this separation has to do. Otherwise, you will be not in a correct plane. The Tolles fascia.
Good dissection, Rajbandhan, coming out well.
So if you are in a proper plane, always I used to say, whatever surgery in a GI track, there will be dissection between the parietal and visceral fascia. You identify that fascia and dissect. You will not be in any abnormal plane. If you do from esophagus to rectum or anal canal, then you can do a bloodless surgery. Unless that pathology warrants a change in the anatomy.
Right, correct.
So all surgeries or GA surgery is about identifying the plane between the parietal and visceral fascia, whatever surgery. So now we have reached our so many people say that okay, we have reached the splenic flexure, it is enough. It is not enough. Whatever, if you do this dissection, it will not be enough. It will not reach the pelvis without tension. So unless the attachment of the inferior border of the pancreas is divided and bring that splenic flexure out, you will not have that extra colon without tension.
Correct.
Otherwise, all the time the tension will be there.
So you will be entering into the lesser side.
Yeah. Still, we have not entered the lesser. Can you see that? Whatever it is, the pull will be there. சும்மா இப்படி பிடிச்சிக்கோ, லேசாக பிடிச்சிக்கோ, ரொம்ப டைட்டாக பிடிக்கக்கூடாது, நீ ரொம்ப இன்ஜுரி பண்ணிவிட தள்ளி பிடி. அப்படி பிடி. I think it now I have to. Now I am changing my right hand working to the left iliac fossa, left lumbar port. What is it? So far, I didn't change the position of the patient. So because my aim is to maximum do the sphenic flexor, whatever from the lateral aspect. You can see the pancreas in this patient. Not all the patient will be seen like this. And you should be careful while you are approaching the hilum of the spleen. Bhavanta, have you noticed there will be one blood supply from the colonic vessel to the spleen? So I have noticed once you
that's
do the
correct.
sphenic flexor mobilization, there sometimes there will be ischemia part of the spleen. Not in all
Spleen.
cases.
Yeah,
Some
especially the lower pole, no, generally it happens. Yeah.
but we don't disturb the lower pole vessel. But only it happens not in all patients. Some patients.
I think we have to be careful about the amount of traction that we give here.
Yes,
Sometimes
yes,
the
yes.
vessel can get avulsed, leading to some troublesome bleeding there.
So that is always whenever you are doing a gastrectomy, there will be more problem for that. But as you said, I have heard even while doing the sphenic flexor mobilization also. So with this, I will stop here. Then we will concentrate our more important point. Okay. So we'll keep the gas piece here to identify whether we are while we are coming to the. Okay. Good. So now the most important part has come. Since from above we have maintained the fascia. அந்த இது கிளாம்ப் உள்ளது கொடுங்க. Hold this. Okay. மேலே வந்து இது போட்டு ட்ராக்கர் போட்டு.
The left side nerve, is it visible or?
Now we didn't open the presacral fascia. You will not see the nerve.
It will be
Unless
protected.
you open. Yes, yes, yes. So here is for the beginners, because of this traction, here is the area where you can see the ureter. Ureter can be tented. So while doing this with the harmonic, you should be careful. This is the area where the ureter can be injured, even in normal patients, particularly female. Will not be knowing because of the ovaries or with some cyst. So you should be careful. So you identify this plane and be careful. You should not injure the ureter. So now what I will do, I will go a little bit posterior, then I will come back. So the TME plane, the dissection is first, you can go posteriorly, right lateral, left lateral, then come anteriorly. It is not like only one side, so you'll be doing in a multiple direction actually. So அப்படி வச்சு எங்க இருக்கு அதை எடுத்துடலாம் கொடு பிடிச்சிக்குது. So I have kept the IMA node here. I will just remove it. So you need a experienced team. So sister was just telling. So we have kept the node. So I have forgot actually. And particularly the camera person should be very experienced. Suction kudu. Otherwise you can't do ultra low anti-resection up to the pelvic. You have to go and dissect. Suck. Up to the pelvic floor you have to go and dissect. You should see up to the levator plate. Suck. So once you have a full dissection, maximum at the posterior, then come anterior, because it looks like CRM is involved. Probably the bladder peritoneum is involved. So I have asked our radiologist. He said the fat plane between the prostate and the tumor or the rectum is maintained.
So once the CRM on this side is involved, what are the tips that you would give us? You would excise the peritoneum?
Yes. I'll excise the peritoneum. So I have shaved even the Kami. Shaved even the prostate capsule actually, one case, but luckily it come negative only. So I have done a few cases along with the hysterectomy. I have excised the seminal vesicle. So in this case,
In this
we have to
patient,
go. Yes, ma'am.
sorry. Sir, in this patient, the MRI was a concern at 3 o'clock position. But
Yes.
when we are operating at 9 o'clock position, also you were a little concerned. Isn't that
Yes.
right, sir?
They said probably because of the desmopathic reaction, been seen like that. But I feel, as you said, I'm a bit worried about this case. We'll see how it goes without much problem.
Raj, with the redundant sigmoid, would you still go ahead and do a sphenic flexure mobilization much before you do the pelvic dissection?
Yes.
Because sometimes you see the colon falling down onto the pelvic cavity, finding it difficult to.
No. Never the colon will come to the pelvis, whatever you do, because head down, maybe small bowel will come. That's why that extra port is there to the retraction. I can see.
The Rajabandhyam, the
Yes.
fascia what you divide, is it anything like Valdes fascia or?
No. That is Valdes fascia, not divided, I feel. Probably Valdes fascia, because we have gone beyond S3. But I feel some infiltration there to the fascia also, or whether because desmopathic reaction. So you can see it is not, the fascia is not, I could not see the fascia properly in the presacral fascia here at the depth. Go there. So what I am planning to do is just go here.
So on the right side, I will be going more lateral.
Yeah. This is quite challenging, very narrow pelvis. So I have to dissect here along with the
And you have pain of dissection anteriorly, anterior to denovelase. Is it
Yes,
right?
yes. It will be yeah. So I will be including the denovelous fascia here. So even I have made an injury to the bladder, I am not bothered. I have to suture it. Huh?
Would cystoscopy be a part of your pre-operative?
Yeah. I have told, but I didn't do the cystoscopy for this patient. I have informed the urologist anytime I will be calling.
Because any
He's
patient where
ready. Yes.
where the tumor is
There,
adherent to the bladder, I
yeah.
think one must also do cystoscopy.
Always cystoscopy. Yes.
Yes.
But MRI doesn't say there is a fat plane is maintained between everything. Okay. Suction. Suck. So this is the problem in all neogenicity. Frequently you have to go suction. இதுல கூட
Raj?
Suck. Yes, Roshan.
Yeah, once you mobilize this, would you do a frozen section of the area where there is an infiltration to see whether
No.
the CRM is positive or not?
I feel this CRM will be positive. For this case, I may not be using the frozen section. So if you are finding a distal clearance margin in case of intersphincter resection, then I will go for. Here, if I finish this, I will go beyond this definitely. If I could not go for the distal dissection margin, yes, I will go for frozen section. So I have informed our pathologist also as well. They are waiting there. Sometimes the perforation. பிடிச்சிக்கோ அங்க பாரு அப்படியே இருக்கும். Probably sometimes I may have to exercise the seminal vesicles. அப்படி எப்படி
So usually you operate a little early. Is waiting for 11 weeks was a default?
No, you can wait up to 12 weeks. Only
You
after
are
12
concerned
weeks.
about the response, sir? Or
Yes, we are concerned about the response because he's not responding and mucinous tumor. So you can't expect more response. It should not become worsen. Okay.
is waiting for 11 weeks the reason that you have a little difficult plane, or it's a bad tumor?
So he was having an interval chemo, sucks. Usually for the radiotherapy to respond, you have to wait for minimum 8 weeks.
Yes, sir. So you said this is
And
around
only
11 weeks, right?
Evidence that if you wait for 10 to 12 weeks, the response will be better.
More response, yes. But minimum 8 weeks actually.
Yeah, but then the longer you wait, also surgery becomes that little more difficult because the fibrosis more
fibrosis is setting.
Yeah.
But I have seen cases like waiting for more than 12 weeks, 14 weeks, 18 weeks, but not much difference. But as you said, the response of the tumor, the pathological response to the treatment. So initially it will be very big. And later, the response is good. Even waiting even for 3 months also not a big problem. If it is not responding nicely after 2 months, then that will be a problem doing surgery also, with all the effect of the chemoradiotherapy plus the tumor effect. Pudichukoma. I feel little bit I can mobilize. There is a இதை பிடிச்சிக்கோ, இதை நீ வந்து அப்படி இரு. என்ன அது கிளீனா இல்லை பாரு. Go near. பிடிச்சிக்கோ, க்ளீன் பண்ணு. எப்படி நீ இல்லை மேம். க்ளீன்.
Dr. Rajapandyan?
Yes, sir.
Yeah, upper 1/3 of the rectum, you treat it like colon. You don't subject for the neoadjuvant.
Upper 1/3 of the
rectum.
Ah.
Tumors is the upper 1/3.
Yeah.
Do
Always.
you consider
Yes, see, many times if you see upper rectum also, if you go say it will be, you will be end up in doing ultra low anti-resection only, what I have seen in my experience.
Regarding neoadjuvant?
Neoadjuvant, definitely. Many cases I have gone inside before neoadjuvant, then we have to do a neoadjuvant. With a diagram, we say everything is involved, go for neoadjuvant like that. So definitely I want to put a stent for this case. அதான் பண்றேன். பிளாடர் ஒன்றும் வரல, பிளாடர் வந்தாலும் ஒன்றும் பிரச்சனை இல்லை. எடுத்துக்கலாம் ஒன்றும் பிரச்சனை. அந்த டியூமர் அதோட சேர்த்து தான் எடுக்கணும். Even if it is opened, I will be taking that. So initially I said no problem. Even a bladder இருந்தாலும் ஒன்றும் பிரச்சனை இல்லை. You have to take along with that. So definitely I will do a cystoscopy and I will put a stent for this case at the end. Make sure.
Now it looks like the bladder has fallen away, right, sir? You are worried mainly about the periprostatic plane seminal vesicle. Bladder has gone away.
Have you changed the position of your TV trolley?
No.
It's the same?
Same.
Okay. What you were using for splenic flexure also?
No, same. Only thing I will be same. I am also didn't change. Probably
planes in the posterior and towards left is okay, isn't it? Hello.
Whether the tumor is extended beyond the serous, definitely is there. Pudi. Pudi. So this area also should be very careful. Here also you may injure the ureter. Pidichuko.
So that's the reason I think most of the people do put a ureteric catheter for lower third rectal cancer.
So if the MR
Not
is
for all
clear,
cases.
if the MR is
Not
clear,
for,
CRM
yeah.
is not written, we may be comfortable doing it without a ureteric catheter. Sir, any locally advanced, or if the CRM is a question, especially in the region of the ureter, probably we'll do it.
Pidichuko.
The other option is that MRI in favor of the good response, then you may opt to go for a total neoadjuvant and then
Convert.
See the response. Is it?
Yeah.
In fact, we may use ureteric catheter more liberally with the diverticulosis because the ureter will be a problem higher up than with a CA rectum if you have a good imaging practically.
Suction could.
Yeah, agreed. Because diverticulitis will involve sigmoid more than the rectum.
Suction could. Yeah.
Sometimes we partially inflate the bladder. That gives us a good idea of planes here.
Yeah, that is I'm planning, as you said. Suck. Suck. So a lot of fluid will be coming. That is a big problem.
If a patient has tolerated neoadjuvant with a lot of difficulty, and then suppose trial dissection becomes tough, is there any point in giving TNT? Because definitely he will have more problems with TNT.
In a non-mucinous tumor, as you said, it's okay. But mucinous, we know it's not going to respond.
So mucinous and poorly differentiated mucinous with and signets will
Yes.
not respond to chemo.
Yeah, that's why we go for
In fact, early intervention is better.
better actually.
See, that is one of my problems with the TNT trials is that if you look at the percentage of histological differentiation, most of their patients are well differentiated or moderately differentiated. Whereas in India, we have nearly 30 to 40% patients who are poorly
With the mucinous, poorly differentiated, yes.
or mucinous, all of which are not very, very responsive to chemoradiation.
If I can bring it out of the pelvis, then it will be good.
I think laterally there is some space that you might get. Yeah, nice.
Distending the bladder as suggested, will it help?
I think they have
Sorry?
already done it.
But
They have already done it.
Done now.
No?
Yeah, bladder is falling down now.
come out. Long போட்டு வச்சுக்கோ. நல்லா தூக்கி இல்ல இல்ல ஒன்றும் கம்மி இது நல்லா பிடிக்கும். Go in between. Go in between. In between. Left down. Left down. Long வச்சுக்கோ. வந்துட்டு just go. Oh. பிடிச்சு செக்ஷன் கொடு. பைப்போலார் கொடு. பைப்போலார் கொடு. பைப்போலார் கால் கிட்ட இல்லை. பைப்போலார் கால் கிட்ட வைங்க.
Sir, as you are handling that small bleed, for the sake of our junior colleagues, can you tell us at what level will you start changing the direction of your dissection so that we don't hit into the sacral plexus, where the curvature of the rectum changes when you go deep into the pelvis? Can you please highlight some practical tips on that?
So just now I was just dividing the Valdes fascia. So laterally sometimes you will be coming across the presacral veins. So don't go very laterally. So you go in the midline only. Then you can see. So unless you divide the Valdes fascia, you will not enter the anal canal.
So it's for
it
the
is
juniors.
like, can you see that?
Yes, sir.
So much depth you have gone actually. So you can see that the baby's butt is the. So you can see like that. Like this. The dissection while they are doing the posterior dissection, they used to say.
So it's worthwhile remembering that beyond the Valdes, it is not going to follow the same curvature, and the curvature is going to turn anteriorly. So we may have to change your dissection direction slightly anteriorly, not to hit into the presacral veins.
Yeah.
Left, right
You
side.
just push, it will be going actually above.
And the thickness of the mesorectum is going to start thinning down below the
Thinning down.
valdeas. So below the valdeas, it's going to be slightly difficult and different plane, and it is worthwhile for all of us to remember when you are in the starting of your career or in a difficult case.
Suction. Long photograph. So what I thought, I want to do a maximum posterior mobilization, but near it is a circumferential lesion. See, circumferentially, it is very much adherent actually. See, right lateral maximum I have removed. I mean, I have released the tumor. We'll see how easily it is coming. It's going to be tough only. So once I release, after that, I will see whether I will just inflate the bladder and see. என்ன பண்றமா? சீக்கிரம் போட்டு. Ligasura. Suction. Suck. Okay. புரியா? So okay. விடு. இருமா. நான் என்கிட்ட கையில கொடு.
If may ask my fellow senior panelists, what are the practical tips to judge on table if you are handling a residual tumor or a desmoplasia? So by experience, how do you make the judgment if I'm going through a desmoplasia or through a residual tumor, sir? So Dr. Anil Haroor and other seniors, can you please share your thoughts on that, please?
I think it's very tough, but plastic reaction like Dr. Raj managed it. Sometimes you can manage it by tears through. You really the tumor or not. I think it's difficult to describe in word, but you can always make
Just
out
generally the residual tumor will be slightly fleshy if you see, as compared to a desmoplastic reaction. More fleshy type of tissue when you're dissecting.
No, your voice is cracking. Hello, your voice is breaking.
Sorry about that. I think I have bad network. But I think to answer that question, when you go through a residual tumor, it will be more fleshy as compared to a desmoplastic, which is more of fibrous type of tissue, which doesn't, fragment as easily as a residual tumor.
Exactly, that's what I meant. That you can really make out that you are going through the tumor. It tears
Yeah.
off, and you can make out that
Yeah,
you
correct.
can see the torn ends, like this. You will not see a plane
Yeah.
like this. What is probably seen now on the left side is the desmoplastic reaction.
Sometimes when you use a monopolar also, the dissection here in these planes becomes a little more easier. The
Monopolar
dissection
hook.
is sharper, the monopolar hook or the spatula.
Okay. But then the problem with monopolar hook is that if at all there is a bleeder in the desmoplastic tissue, because of that fibrosis, it doesn't contract and it goes on oozing a lot. So
It has to be a combination of
yeah,
monopolar bipolar,
yes,
like we do it in robotic.
right.
Here. Keep like that. Update.
At,
Open
at 11 o'clock, it's really a little of concern, right, sir? It's looking a bit fleshy at 11 o'clock. So are you going to take
That's
the,
right. I'm
yes,
going
sir,
to
are you
take
going to
alarm.
take default the seminal vesicle also en bloc, sir?
Yes. I'm just planning. Probably that seminal vesicle has to be taken like that. But this is seminal vesicle.
Raj,
With the
would
vase
two
rather than is it the vase rather than the seminal?
That is
That's the
seminal
first
seminal
one
seminal
from
vesicle.
this.
பிடிச்சுக்கோ. சக்ஷன் போடு, பிடிச்சிக்கோங்க. எடுத்து சக்ஷன் போடு. லாங் சக்ஷன் தானே வச்சிருக்கேன். லாங் தானே இது. சரி வைக்கல. சக்ஸ் அப்படியே போடு. அப்படியே. Turn that side. Keep like that. பிடிச்சிக்கோ. Mm. பிடிச்சிக்கோ. பிடி. Update. Keep like that. Come out. I don't know. What happened, man? Suction, man. Suction. Okay, good. Come out. Good. Yes.
Dr. Ajubandyu? Yeah, in a narrow pelvis like this, you think robotic will be better than this?
I have tried maximum from the robotic, then I come out to lab for doing such cases. So probably give me some more time. I will give. At present, what I feel, even robot reaching there will be a bit difficult actually. If it is narrow, it is narrow only.
Okay.
Only thing the camera, depending upon the camera and right hand working port and left hand working port. So much of traction should be given by the assistant ports. In a clean case, it will be easy. But narrow pelvis, very obese, rectum, fully occupied rectum like this, then it will be difficult for anything. And as you said, if the bleeding comes, means then it will be with the bipolar only will be there. But of course,
How much distal margin are you aiming at?
maximum. So I am going to dissect up to the pelvic floor.
Yeah, till the
So,
levator.
yes.
Yeah.
So,
But if you have difficulty getting it, can you settle for about 2 centimeter? This being a
no, distal third, even if frozen section is negative, that is okay.
Yeah.
Even less than a centimeter also, frozen section negative. So I have done a few cases with only 0.5 centimeter. Till they are doing fine. So all this thing is told. So even if you have, but our aim is to have at least macroscopically 1 centimeter.
Yeah.
Once this has come, definitely we'll have a good clearance for this fellow.
Yeah, but that depends on the grade of the tumor also. If for well differentiated, I think it's 1 centimeter.
Now that is changed.
Yeah.
Even poorly differentiated after neoadjuvant CTRT, you can give yes. But nowadays, all the adjuvant has come, no? So you
Okay.
give the TNT. Hey, suction. Suction. Suck.
But once you clear the problem area, then the margin won't be a problem. I think then you will get
Yeah. This is the seminal vesicle. I'm seeing where I will be going like this. This is the prostate. Seminal vesicle and prostate. That is not involved. Okay. Good. Harmonic update. Ligature எடுத்துக்கோ bipolar வச்சுக்கோ.
this retraction, fan retraction is 10 mm or 5 mm. This
5 mm. அப்படியே ஏய் பிடிச்சுக்கோ. லெஃப்ட் ஹேண்ட் பிடிமா அப்படியே. ஏய் hold this like that. அப்படியே பிடிமா.
Very nicely, you're doing it millimeter by millimeter.
Yeah. So I don't want to lose anything.
Yes,
I don't want to left anymore here.
agreed.
So take your own time, be very patient.
Yes.
Even small mistake, then it will jeopardize. What like this? Keep like that. So this is the another.
That's the left side seminal vesicle.
Yes. So I'll preserve that also. Keep like that.
Probably it looks like we have gone beyond the planes of concern.
Yes,
Correct?
yes. So now only thing how the time how to divide that. பிடிச்சுக்கோ. I think so. Once
At
the
what time
tumor is
in this
out of the
operation you are going to
pelvis,
ask your assistant to put a finger in the rectum to guide you, sir? So when will you request a PR? At what
not
level of your
now.
resection?
No, up to once I reach the, I mean, pelvic floor, levatrani, on all side, then I will ask them to put. So I have asked sigmoidoscopy also to be ready. Okay. But in this case, maximum low down you have to go. Jayadu kudu, suction kudu.
Very nice
Yeah.
resection done that.
So till we complete the suction kudu. Suck. So once you bring out the tumor out of the pelvis, then the problem is solved. Keep like that. Come out, come out. Go near. Turn right down. Did he apply const? Adir. Allah alipuri. Wow.
The problem with deep pelvic dissection is the smoke. Do you use
Yes,
smoke
yes.
evacuators? Smoke evacuators will have.
Yeah, we are just planning. Usually during the conference I used to use.
Right.
That is useful only if you are doing a TAMIS or a transanal microscopic surgery.
Yeah. Other thing is, I usually
Yes,
keep suction.
Yeah. Usually there is one
Slightly,
this thing. They'll put a small needle and there will be continuous small suction. பிடிச்சுக்கோமா.
or you can use a laparoscopic sucker and ask your assistant to keep a
Yeah.
small amount of
The sisters will be
suction.
using that. There is one small this thing continuous suction will be there.
Yeah.
So nicely we have dissected. Still okay.
Great dissection. Great
Some more.
dissection.
Yeah.
Yes.
Anyway, some more we have to go to have. Otherwise, we have. So all circumferentially you have to go to the. Oh.
As we start going
This
down
is
close
a
to the
vessel coming
pelvis,
from the. This is coming from the rectum actually. So usually there will be periprostatic plexus of veins will be there. Don't remove the.
so in the lowermost rectum, especially when we have a low rectal tumor, the concern is rectal perforation as much as is there a concern for a positive CRM. So how do we balance this out?
Sucks. So if there is a, if you feel there is some perforation in the low rectum, then we have to plan for intersphincteric resection, do a frozen section. Mostly you'll be knowing during surgery itself or pre-operative you can plan whether you have to go for a APR or a intersphincteric resection with a frozen section. Okay. So I'll go a little bit on the left side first, then I'll come from the right side. பிடிச்சுக்கோ. So now we can see it was not infiltrating the prostate or much of seminal vesicle. Both are just adherent. It is not infiltrating. Okay, now you can see easily it is going up. Anyway, the left, come out, come out, come out. There. Suction kodu. இன்னொரு 5 m எடுத்துக்கோ. Suction. So we have to use a long suction nozzle, long harmonic scalp, everything. I don't know whether people have watched. So I have just changed the long harmonic scalp handle because it will not reach. So all these are very important while you are doing ultra-low anterior suction. Come out. So now only we have reached the anal canal. Oh God. மாற்றக்கூடாது அப்படி பாரு இங்க பிரிச்சுதான் இருக்கணும் இப்படி இப்படி
No, the mesorectum is appearing like baby's bottom.
Baby's bum. Suction code. So mostly we have reached the levator on the left side and left posterior aspect.
Yes.
Suck. Quite a long rectum and very narrow pelvis. This fellow is a very short fellow. Suck. Suck பண்ணிக்கிட்டே இரு. குடு. Okay.
Dr. Ajibandyan,
Yes, sir.
which level you divided Valdez fascia? Can you show that?
Yeah, already. Yeah, when I divided, I was telling.
Yeah,
It is at the level of S3. Yes, but we could not see.
Can you
But
point out
once
with
I,
the harmonic
yeah.
roughly
Yes,
the
yes.
area?
Here, can you see that?
Yeah.
That is the Valdez way. Here.
So after dividing, you have to go up towards the mesorectum, away from the sacrum, isn't it?
Yeah. You just push it, you will be seeing.
Yeah, it's a loose areolar tissue.
It is, yeah. Semi-circumferential dissection. Like baby's pump has come. Suck. Left down. Suck. விடு. எப்படி come out. Suck. Do that.
Should we have an assessment from bottom PR? To see
Yeah, I'm just waiting. I still I see the pelvic floor circumferentially. Then only ask our assistant to go and do a PR.
By pushing the perineum with your assistance or somebody's fist will also lift a bit of perineum, isn't it?
Yeah, that is still I have not come to that stage.
Come to that stage, yeah. You are almost there, Dr. Nice.
Yeah. It will be there, but for putting the stapler, it will not be enough.
No, I'm talking not the putting the stapler. If your assistant can go behind and push the perineum up, then then it will be a bit lifted.
Dr. Bhavandar, do you routinely do in difficult cases?
I do, yeah. I do. Assistant will come at the perineum
left up.
And with the fist of the
Do
hand.
you put a mock or something like that, and or gauze on a sponge holder, something, or whatever? How do you do it? Just with the hand?
No, just at the anus around the perineum, you ask the assistant to pinch your hand, and then with your fist you apply some pressure. Then your perineum get lifted, and the dissection will be bit easy.
Or you can even use a mop or something like that and use the fist to push it.
Yeah, always use some pad and with
Yeah.
the fist, not with the blind fist. Yes, some mopping pad.
Yeah.
Yeah.
It's with a thick piece of gauze, and then you
Yeah, it is pad, not
put
the gauze. Yes.
with the fist. Yeah.
Come on, come on.
Dr. Rajavandan, just for a discussion, not in this case, early rectal tumor or a colonic tumor, localization like preoperatively, like with the ICG, do you have any like a dye injection? Do you have any experience?
Sorry, I couldn't understand. For the
Like a small
metastasis, a small tumor.
No, small tumors, like in which cases we'll have difficulty in identifying during surgery.
Oh,
So the
that
localization of the tumor.
That I will always do the sigmoidoscopy.
Okay, and mark the location.
Yes, yes.
Roughly have an assessment where it's going to be.
Yeah, tattooing can be done by the endoscopist. So,
tattooing with what?
India ink.
with India ink, yes.
But off late,
that is for the colon, not for the rectum.
Yeah.
No, but
even for rectum or rectal sigmoid also, yes, you can do. Yeah, Indian ink they will inject endoscopically. That is mainly for the colon cancer. Pudima. If you have a doubt, but preoperatively we will manage. So only thing if you do right hemicolectomy or extended right hemicolectomy like that.
Otherwise, what Raj said is true. We can do on-table sigmoidoscopy and localize.
Yes.
Only thing is insufflation may cause too much of insufflation difficulty in procedure.
Yeah, that we have to block with the forces, bowel holding forces or special forces to maintain the. Bipolar. Pudi. Suction. Ligature. Bipolar. Suck. Left down. Ligature. நீ வந்து அதை பிடிக்க very important. Suction. You can see the interstitial fluid below the presacral fascia. Harmony kuda. Come out. We have reached the levator ana, on the right side as well. Very. Adipudi. Udu. Adipudi. Adipudi. Alitipudi. Oh shit. Bipolar kudu. Suction board suction. Sir, bipolar kudu.
ஒரு காஸ் பீஸ் போடுங்க.
அது எப்படி? Suction kudu. கீழே சக் சக் சக். Gas piece good. It's coming from the prostate. Bipolar good. Will stop all venous roots. Gas piece on section put na put first. Gas piece ala put. Kudu gas piece kudu. Clean பண்ணு. இது குடு. Retractor குடு. அதுக்கு அந்த மாதிரி பிடிச்சிட்டு இருக்க செக்ஷனா. Clean பண்ணு. The pudi, yes, retractor pudi. Out. Needs suction all very good. Suction. Suddenly it is. How did it? Suck. Gas piece kudu. எங்க இருக்கு? Gas piece காணோம். என்னன்னு பிடிக்காம இருக்குமா? இதை பிடிக்கணுமா? புடி. கேஸ் பீஸ், இன்னொரு கேஸ் பீஸ் கொடு. சாஸ் பீஸ் எனக்கு தெரியல.
இன்னொரு காஸ் பீஸ்.
ஓகே, இன்னொரு கேஸ் பீஸ் கொடு. சக். இப்படி வச்சுக்கோ. அடிப்படி. I think there is a bleeding from the prostatic plexus. Okay. More. First time I went for like this. Suck.
I think bit of pressure with some gauze.
Yeah.
Get the
Just you have
posterior.
to wait for 5 minutes for pressure.
Yeah.
Usually it will very, very rarely it will come.
Yeah.
Because of the tumor
Humor and
stop
very narrow
reaction and it
pelvis.
is,
Isn't it?
narrow pelvis.
Yeah.
So once the bleeding comes, all the plane will disappear.
That's the thing. Yeah.
Huh? No, வச்சுக்கலாம் சார். உட்கார வெளியே.
As we are waiting, can we ask for a parietal examination to figure out where we are, sir, anteriorly? Sir, as we are waiting for the hemostasis, can we do a parietal examination to find out where we are anteriorly?
No, not now. We'll see.
Right.
Because still we are not come across fully.
Right, sir.
That stage we have to dissect some more. Sucks.
So anteriorly, you feel you have a little more to go, sir.
Yes. Because it is probably it is a lengthy tumor. What we have seen is the only lower. I mean, this is the upper border. Lower border still down. Sucks. That's why the 6 centimeter, 5 centimeter rule and all, it likes ultra low only. I mean, very low tumor.
You can dissect posteriorly.
Yeah.
That will also keep applying pressure on the prostate.
Yes.
Isn't it?
That's why I'm just planning.
For the posterior dissection.
Go in between left arm. Put it, suction kudu. Idu kudu. Keep like that.
You are using 30 degree
I'm using
telescope,
30
aren't you,
degree.
doctor?
Sucks.
Okay.
Sucks. Hey, come on. Okay. Harmonic kudu puchko. Come out. That is the muscle. So you enter the levator and posteriorly. So I am dissecting the intersphincteric plane actually. Foot தூக்கி பிடிச்சி அப்படியே இரு.
Just for the trainees, advantage of using 30 degree, you can run the light cable into 6 o'clock and then you can get a good view when the anus is ascending, lower rectum and the anus, isn't it? then you can go into the intersphincteric plane very clearly. So your camera surgeon is doing an excellent job, Dr. Rajapandi.
Yes. That's why you have to have an experienced camera person while doing particularly ultra low. The camera person is the eye of the surgeon laparoscopic. Suction. The same person, when we do the first sigmoidoscopy, we can go through the lesion. So scope is not, scope could be passed beyond. But when I did just yesterday, we could not pass the scope beyond the tumor. That's why I feel this patient is not have a good
Right.
response.
Yeah.
Yes.
And with the radiotherapy, there will be tissue
But
edema
usually
as well,
they'll have a
isn't
good
it?
response actually.
Edema and
But unfortunately,
so probably very aggressive tumor, mucinous tumors are aggressive, isn't it?
There seems to be a vein there, isn't it, Raj?
Yes.
Would a bipolar or a ligation would be better there?
Where?
Where you are dissecting at present, where the vein is.
No, actually, these are the muscles. Actually, what you are seeing is the rectal muscle. But vein is there. Okay, we'll see. Long kuduma idella. So tumor is out. But still I am not able to bring it fully out. Left down. Those are younger forward.
So I think we are holding a content of a one side vase, and if you do that, you may actually go anteriorly, no, sir.
So I'm just thinking.
So if you want to go extra TME, probably the vase and the seminal will come into your specimen.
Already I have cut that seminal vesicle on the left side.
The vase has
So I'm
been
going
cut.
to bring.
Seminal is on the specimen.
அப்படியே எப்படி பைப்போலர் இது கொடு, லிகாஷர் கொடு, லிகாஷர் கொடு. இரு அது எப்படி அது இருக்கு. Left lateral side I am okay, but still on the whole keep like that. அது எப்படி அப்படி எப்படி சக்ஷன் போடு, எடுத்து சக்ஷன் போடு. இதுல ஒரு ரிட்ராக்ஷன் போட்டு பிடிக்கலாம், லாங் பால் ஒன்று போட்டு சக் 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 சக். இன்னொரு காசு பீஸ் எடுத்துக்கிறியா? ஹார்மோனிக் கொடு. Come out. அழுத்த மெதுவா அழுத்த. அடிப்படி அவர் ஓப்பன் பண்ணாம பிடிக்கணும். இப்ப அப்படி இப்படி இங்க பிடி. அது தொட்டன் இதாகுது. இது பட்டாவே இதா. கம் அவுட் கேமரா அவுட் மெதுவா. டன் பக்கத்தை கால் கிட்ட வைங்க கரெக்டா. இதை கொடு. நம்ம லிகாஷர் கூட அப்படியே பிடி. லிகாஷர் அப்படியே. This is the area where அப்படியே. எங்க காமிக்கிறீங்களா? Yes. Yeah. விஜய் இது பண்ணிட்டு வா. கீழே பிஆர் பண்றது. Come out. எப்படி ஆமா செக்ஷன் போடு. Everybody. Suction. Come out, come out. Suck. Suck. Ligash டக்குன்னு போடு. வேற காஸ் பீஸ் எடுத்துக்கோ. நீ இந்த ட்ராக்ஷன் நல்லா இழுத்துப்படி. Camera out, camera. Suction. இந்த காஸ் பீஸ் இங்கே இருக்குது, அப்புறம் எடுக்கணும். உள்ள இருக்கு, இன்னும் எடுத்து வச்சுக்கோ. சக். கம்மியா. பிடிச்சுக்கோ.
Digital examinations done or going to be done?
It's going to be done. But I thought it is a small tumor, but it is really a long, lengthy tumor. So we have dissected up to the pelvic floor, both posterior and laterally. Anterior also you can see because of the muscle. இப்படி நீ ஒத்த கோயில் பிடிச்சிட்டு வேற இன்னொருத்த வர சொல்லுமா, பிடிச்சிட்டு இன்னொருத்த வர சொல்லு. இது ரொம்ப டஃப் கேஸ் இல்லை. பார் இங்கே வந்து வருது. லிகாஷர் போடு. நீ காமன்ற இங்கேருந்து வந்துருக்கணும். அங்கே பிடிக்கக்கூடாது. அப்படி இப்படி இங்கே தான் பிடிக்கணும். அங்கே பிடிச்சுன்னு இதாவது. லிகாஷர் போடு. Okay, it is from the muscle only.
So we have reached up the pelvic diaphragm.
Yes. Only thing I don't know how I'm putting the free. Whether we can put a stapler or intersphincteric only you have to go.
Stapler probably 45 cartridge maybe go in. 45.
I will see. Before that suction could. Come here. What பிடிச்சுக்கோ. கலந்துருச்சு பார்.
Clearance is good, no? Clearance.
Sorry?
Clearance is reasonably should be
good.
Yeah.
Clearance should be good. Distal clearance only you're asking, no?
Yeah, distal.
Yeah. I'm just looking for that only. I need lamp உள்ளது போடு முதல்ல. போடி. Go near. So one more you give. கலந்துட்டு வருது பாரு. உடஞ்சே போகுது. இன்னொரு 5M கூட. ரிட்ராக்ட் போடு. இதில் போட்டுட்டு அதில் வந்து இது 10ல வந்து அது எப்படி சக்ஷன் இதில் போடு. ஃபஸ்ட்டு க்ளீன் த லென்ஸ். அதுக்கப்புறம் ஹார்மோனிக் போடலாம். வேணாம், இப்போ ப்ளீடிங் இல்லை, ப்ளீடிங் ஆச்சுன்னா பார்த்துக்கலாம். சர்க்கிள் ரெக்டல் கிளாம்ப் இருக்கா? என்ன கொடு கொடு, ஹார்மோனிக் கொடு.
Dr. Rajabandi?
Yes, sir.
Would you like to further skeletonization of the rectum, or it's almost over? Okay, no?
Yeah, almost. I'm okay, but I want to put a stapler. Still, in and around the levator plate, I want to just dissect because this tumor is.
Suppose if the digital examination from below shows a reasonable.
Come out. Adequate length.
Yeah, then why don't we go for stapler because for this skeletonization, will it create problem?
No. Still, we can't put a stapler unless you have a அதில் தான் போடணும் ஸ்டேப்லர். No, putting the stapler, before firing the stapler, you have to make sure circumferentially you have a good space. Otherwise, it will be going obliquely. So I want to make sure before going to stapler, I want to have circumference. This is quite a big tumor, and it is fully occupying the whole rectum, my pelvis. Though it is out of the pelvis, I can see. Pidichko.
Because
Only
you make
go there.
2 cartridges, and I think that will it be possible to do it with?
I think bit more dissection from the right side will
Yes.
it up, isn't it, Dr. Rajapandian?
Yeah. Bit more dissection on the right side, then it will
Right
be
side.
okay.
Yeah.
No, circle the fan be detect வேற வாங்க நிக்க மாட்டேங்குது பாரு. No, எடுத்துட்டு வா. எடுத்து போடு. Hold this. Put suction கொடு.
Dr. Bhavendra, you feel more dissection to be done?
Dr. Vagish, I think on the right side there is a little bit of tissue in that area to be released. Then entire thing will be can be pulled out bit more. Then I think we should be able to fire.
And the question is, will a stapler go and sit there with an comfortable?
You need a 45. I think maybe 2 or 3 45 reticulators. Maybe 2 actually.
And we haven't got a digital exam done yet, sir. So probably we'll have to wait for that before he decides on his comfort in firing a stapler.
Byproduct. Yeah. Surgeon is ready. I'm not only, I'm just waiting for the suck. I want the plane to be very clear. I think this is okay. What?
Because looking at the
I think that is tumor free. I think that is tumor free.
Yeah, that is tumor free.
I think that is
definitely. Tumor is here only. I can see that, but I want. So I want a little bit blood free also.
But in a very, very difficult situation, we have shown the patients and gone down to the pelvis, especially anteriorly, sir. Fantastic. Hats off.
Suck. Suck. Harmonic. Hey, அங்கேரு தேத்துரு ஏன் மாத்தன அப்படியே ஓப்பன் பண்ணு இது எங்க பிடிக்க இல்ல அப்படியே நான் பார்த்துக்கிறேன். இங்க போனா ப்ளீட் ஆகுது. ஹார்மோனிக் கொடு. நீ அப்படியே come out.
You're looking out the video from here, unable to make out the right plane from here. Probably you will be seeing on.
Yeah, I am seeing. There is a vessel there.
That is a muscle, isn't it?
Yeah.
Pelvic diaphragm.
there is a vessel highly vascularized because of the neovascularization. So even small. Okay.
Dr. Bhavanda, are you seeing the video?
No, I have lost
Yeah,
the video.
even
Dr.
I
Aris.
lost.
Yeah.
Put it. Put it. What is it? Hold like this.
The screen looks blacked out, sir. Is it only for me or for everyone on the transmission? Can they be check?
Then now the video, we have the video output now.
Yeah, I also can see the video.
Wipe இது லிகாஷன் போடுதுல அடங்க கரெக்டா போட்டு நல்லதான் அது நல்ல லிகாஷன் என்ன பண்ற பிடிச்சுக்கோ keep like that come out harmonic கொடு come out ஏய் அங்க காம கரெக்ட்டா கோனியர் உள்ள போ. ஃபோக்கஸ் பண்ணல. அங்கே இறங்க. அப்படி தூக்கி. This extra tissue is giving more problem for me. ஓபன் பண்ணு. அடி பிடிச்சுக்கோ. இங்க வா. அப்படி. கம் ஆன். இங்க. அப்படி வந்து லெஃப்ட் உள்ள போய் லெஃப்ட். Yes. So the anterior intersphincteric spain is not easily made out.
Those are rectal wall vessels, aren't they? In the anterior intersphincteric plane. Yeah.
Oh shit. That's why the bleeding is coming, and every time I'm going there,
Yes.
muscle bleed and everything is coming. That's They're all messy. Okay, now I am satisfied. Okay, come out. Keep like that. See, எப்படி வைக்கணும். So this is the one you have to see like a stretch. Come like this. So from one end,
the staple will be coming. The staple will be coming from where? From anterior or
from anterior suprapubic region only.
Suprapubic. Okay. So I think if, with the first stapler, the tumor will come out.
Yeah.
There will be more space and better.
I think we should be able to fire 45 definitely.
Yeah. Looking from here, we get a feel that you are working very close to the rectal wall. We don't know. We may be wrong.
Sorry.
Looking from here,
I am just close to rectal wall only. So I want to see like this. Like this. Now, so intersphincteric I have done extra delay. Probably a little bit more on this side, but more bleeding here. So this is the area. Suction kudu. Now you put the finger on one side. Suction kudu. So now we should be able to. எதுக்கு அது ஓபன் பண்ணி வச்சிருக்கா? ஏமா இதில் ஓப்பன் பண்ணா இல்லை சக் 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 சக். Okay. Only thing you have to make sure, yeah. So once I see like this, then I happy. See, circumferentially you should have, then only you should fire.
Okay.
Wait a minute, man. So posteriorly, you are touching my instrument. Nothing is there. Okay. Laterally, laterally, touch. Okay. Anteriorly, nothing is there. Are you able to touch the tumor? You will not be able to because you are mobilized. You are not able to. Yes. So tumor is well away. Okay. இது கொடுமா rectal clamp கொடு. So we have a vascular clamp. Before firing, always I will see whether I am in the right direction or not. Okay. இப்போ வந்து இதுல வந்து இது போட்டுக்கோ. இதுல இல்ல ஃபேன் பை ரிட்ராக்டர். இதை விட்டக்கூடாது. இங்க வேறு இது இப்படியே தான் பிடிக்கணும். Go near camera. இப்படி பிடிச்சுக்கோங்க. இரு விடு. அந்த இன்னும் மாத்தினே இல்லையாமா? அது இதே மாதிரி அதே மாதிரி இருக்கு. அப்படி இப்படி கிளாம்ப் கூட கம் அவுட். கேமரா லெஃப்ட் ஆன். ஓகே, கம் ஹியர், கம். கீழே பாரு. So up to the pelvic brim, come here. Okay. So I am satisfied, so I can fire the fire. Okay, good. But still you should, while firing, you should be very careful.
You use 45
no, I am going to use
60.
என்ன கொடுக்குறீங்க? போகும் அது இல்லை, நம்ம ரொட்டீனே போட்டுக்கலாமா? ஆமாம், எத்திக்கான்னு கொடுமா. சரி, ரொம்ப டிஃபிகல்ட்டாக இருக்கு.
ப்ளூ, யூசிங் ப்ளூ.
No, golden.
Gold.
First ஒரு fire பண்ணிடலாம்.
12 mm trocar.
Yeah, I'm just changing to 12 mm trocar for the stapler suprapubically. Go near. இப்படி இருக்கணும். இது இந்த இடத்துல பிடி.
Power stapler or?
So I'm just waiting for the power stapler, but I feel I will use the என்ன இங்க பாரு. இதே மாதிரி இப்படி இதை புட்டி இப்படியே. அது எதுவும் அது இடிக்கணுங்க. சும்மா அப்படி இருக்கட்டும். இது வெரி இம்பார்ட்டன்ட். இது இப்படியே தான் இருக்கணும். இதை திருப்பக்கூடாது. இடிச்சாலும் பரவாயில்ல, இல்லாட்டி அதை எடுத்துடு, அதில் போடு. அதை எடு, இதை எடு. கொஞ்சமா இப்படி திறந்துருக்கணுமா? இப்படியே தான் இருக்கணும். ஒன்றும் பண்ணாது. கொடு. அது பரவாயில்ல. உட்கார்றது இருக்குது, ஏன் எடுக்கிறோமா? கேமரா லெஃப்ட் டவுன். இப்போ கீழே வந்த பக்கமா? கீழே வா. கம் அவுட். கம் அவுட். ஏய், மெதுவா. பிஆர் பண்ண. ஓகே, எவ்வளோ இருக்கு? See, only 2.5 centimeter, 2.5 centimeter we are given. Anteriorly, until around 3 centimeters should be there. So for the head of the stapler to accommodate. Okay, சரி, 1 minute பார்த்துக்கோ. So what is the time? So once we disconnect, then we'll go for the lectures.
You have done very well, Dr. Rajpandya. It's a difficult case.
Not at Bhavata, we'll see.
I know. But it's not bad. Timing wise, very good, I say.
Yes.
Very good demonstration.
Definitely
difficult case.
Difficult case, but not for the beginners. Those who are not done, they'll be afraid whether they have to proceed. Not all cases will be like this. Okay. So I have already, like a previous hopefully it has fired nicely. So I have a virtual live for both the male and female. Just last week I did one case, like similar, but it is not this much difficulty. So I thought if it is difficulty, then we will show that for the beginners.
So you'll be doing a covering stoma.
Yeah, definitely. All ultra low air and intersphincter section will go for a covering stoma.
Ileostomy or colostomy?
Ileostomy.
Always ileostomy.
Yes. Okay, 1 minute kalichudan.
And for the trainees who are watching, when you put the circular stapler from anus, you have to be very careful. If you push it hard, then
if you push hard, then it will tear.
You don't have much length.
Pudi. Suction put. Go, go,
Sir.
go near. Come out, come out, come out. ஓடு ஓடு. அப்படி பிடி, இப்படி பிடிச்சுக்கோ. Clean. The rectal clamp கூட ஒரு தடவை திருப்பி ஒரு தடவை. Go, go, go. Come on, come on, come on. பிடிச்சாலும் ஒழுங்க மாட்டோம். அப்படி எப்படி இப்படியே காய்வேன். நீ என்ன காமிக்கவே மாட்டேங்கிற. ஓகே, இப்படி மெதுவா இப்போ ஒரு பக்கம் இருந்தாலும் காமிக்கிற மாதிரி வரும். Okay, 1 minute. Come out, come out, come out. விடு விடு. கீழே பாரு. ஓகே. Okay. So I may require one more stapler, we'll see. Otherwise I'll put a clip there. 1 minute ஆயிடுச்சா? So when the division is over, ask MRI pelvis ரெடியா இருக்கு சார். MRI pelvis அடுத்து TNT அப்படியே போட்டு. So while doing circular stapler again will show. ஆச்சா? Go near, go near. லாங் வச்சிருக்கே. என்ன வச்சிருக்கு இதுல? லாங் தானே வச்சிருக்க. லாங் லாங் Come out. அப்படியே பிடி. சக்ஷன் போடு மேல. ஆடு. இன்னொன்று கொடுத்துரு. Even we have included little bit of muscle also. One more kuduma.
That reticulation is required.
Sorry?
Reticulation of the stapler, next stapler will be required because that head is, if the stapler is pointing towards the pelvic diaphragm, there won't be against that firing may not take place. Because there is not much space lower down.
Come out. Go. பார்த்துக்கோ. ஆயிடுச்சா? அச்சா. Go near. Okay. அச்சாமா. கிளிப் ஒன்று எடுத்துக்கோமா. இல்லையா? கிளிப் ஒன்று கொடு. எப்படி பெரிய கிளிப் கொடு. எங்க காமிக்கிற கேமரா போகணும்க்கா. இட் இஸ் பீன் கிளிப் ஆயிருக்கு. கொடு, பெரிய கிளிப் கொடு.
Stapler has gone up to the...
Yeah. You can see the distal margins. This all stapler has been fired. But stapler. Yes.
Then we can cut it out.
Yes. No? But properly I will put a clip for extra. At least put scissor kodu. Come out. Okay. Good. Oh my God.
Really tough pelvis, sir.
Tough case.
Fantastically
Really
done.
tough.
You really held your temperament in dissecting the anterior part. Fantastically done.
Irrigation. Suck.
Very narrow pelvis.
Very narrow pelvis. Suck.
Yeah.
Irrigation on பண்ணியா? Yeah.
So, doctor, why you have given full bowel prep with
Yes.
oral antibiotics?
Always bowel prep with oral antibiotic. Okay, Bhavanta, I think meanwhile, before coming for the circular stapler, I will call you. So we will running out of time. I will ask that 3 lecture is there, like 5-10 minutes lecture. We'll go for the lecture, just moderate that also. Okay. Meanwhile, once we are getting the circular stapler, I will remind us which one
well done,
call you.
Dr. Rajman. It was fantastic.
Okay, Balu?
Fantastic.
Right, sir. Thank you, sir.
Excellent demo.
Okay. Thank you.
Good evening.
Dr.
Good evening to all. Good evening. This is Dr. Parsardi. I like to tell about the one event we are conducting a conference in November, and actually this is like a road to lab research, so that we are doing planning for every month some live surgery with the lecture, and this conference is on November 19 to 22nd. 19 is the pre-congress course, 21, 22, 20, 21, 22 is a live surgery. I think you can get all the detail from LabResearch website. So even a registration is going on. Just I want to tell that the event we are going to conduct, and so I think all of you know about the LabResearch. It's all morning to evening will be the live surgery, and we are planning in 4K transmission, and 2-3 hours will be the panel and the debates and lectures. And I'm watching the entire this Rajmanian surgery with the Apple Vision Pro. Even you can see in the now I'm wearing here, and so this side is the entire big screen. I'm watching that surgery. It was so wonderful. And so this with this transmission is a HD transmission, and if your 4K also is there, if your bandwidth is good, you can able to see. And most of the time you will get a HD. And if you're seeing in a big screen, it is like watching a live surgery, because moderator from different places they're moderating. So that is the beauty of this Televersity transmission. I think the moderator enjoy this transmission. I hope that delegates also they can enjoy the transmission and the technique. Thank you so much.
It's great, Professor. Well done.
Thank you, Dr. Bhavanta. And now you can go for a lecture. Yeah, thank you.
Thank you, sir.
Is Dr. Anil and Pradeep Sharma is there?
Thank you, Pastor.
Head up. Tough case on the matter. இல்ல அதுல தான் நமக்கு யூஸ் இருக்காது. நெக்ஸ்ட் கேஸ் யூஸ் பண்ணுவோம். நான் ஃபர்ஸ்ட் நான் யூஸ் பண்ணியிருந்தேன்னா பரவாயில்ல.
Can we get the audio to Dr. Viram?
Good evening, everyone. Am I audible?
Yeah, pretty much, sir. You're audible, yes.
Okay. Good evening, everyone. I will be speaking on the role of MRI in rectal imaging. So the prognosis of rectal cancer is related to the tumor infiltration into the mesorectum and ability to surgically achieve the negative circumferential resection margin. This concept of total mesorectal excision and NACT-RT in loco-regionally advanced rectal cancer is based on MRI features. So MRI is the preferred staging modality in CA rectum currently. The role of MRI is for primary staging, for selecting patients who are candidates for neoadjuvant chemoradiotherapy, then guiding surgeons in surgical planning, identifying the poor prognostic factors such as extramural vascular invasion, mucin content, involvement of mesorectal fascia. Also, after treatment in restaging, it can help in evaluating the tumor regression for surgical planning and detecting a clinical response along with the results of digital rectal examinations, endoscopic procedures, and monitoring treatment response for patients who we can't do surgical treatment. Also for identifying the recurrence. Then this is a brief review of the TNM classification of rectal cancer. Basically, role of MRI comes after the T2, T3 and T4 stages. T1 is limited to submucosa, T2 muscularis, T3 lesion is extending into the subserosa and mesorectum. So it is subdivided A, B, C, D according to the depth of invasion into the myometrium beyond the muscularis. T4A involves the peritoneal reflection and T4B involves the adjacent structures. The nodal category is divided as N1-2 based upon less than 3 or more than 3 number of mesorectal nodes, and metastatic M category is divided as M1A, that is metastasis confined to one organ or more than one organ. The rectal protocol, it includes the following sequences. Sagittal T2, it is helpful for the longitudinal location of the tumor longitudinal extension. Then oblique axial T2 is important for the lateral location and spread into the mesorectum. The oblique coronal T2 is useful to look for the sphincter involvement. Next, the diffusion imaging. It helps in the determining the cellularity of the tumor, and pretty much important in post treatment response evaluation. Then lastly, we take a large field of view T2 MRI without fat sat in axial plane to cover the entire pelvis from the aortic bifurcation up to the sphincter, which allows the evaluation of distal lymph nodes like inferior mesenteric, lateral and inguinal lymph nodes. This is a sagittal T2 weighted images. This is used to define the boundaries. Like one is the sigmoid takeoff, the rectosigmoid junction. The point at which there is a perpendicular orientation of upper rectum as compared to the bony wall, that is the sigmoid takeoff. And the anorectal junction, that is the line joining the lower border of the pubic bone with the lower border of coccyx vertebra. It marks the junction between anal canal and rectum. Now on sagittal images, we can divide the rectum into upper, mid and lower, depending as the segments of 5 centimeter in length each. Then surgical or anatomical anal canal, we can see on MRI as the anal canal as a squamous epithelium which is hypointense on T2, which is lower down, and the rectum as a columnar epithelium which appears bright. So this we can distinguish. One more important on sagittal images is the distance from the anal verge. The anal verge is the junction of the skin and epithelium of the anal canal, and we need to report the caudal margin of the tumor from the anal verge. Then axial images. Axial images, there are various anatomical landmarks. We'll start from the rectum. The rectum, it has typical gut signatures like rectal wall layers, which is the innermost hypointense is the mucosa. This hyperintense outer is the submucosa, and outer to this is another dark layer, that is muscularis. It determines the T stage. T1 submucosa, T2 muscularis, and T3 is beyond the muscularis. Then surrounding this rectum, there is this bright mesorectum, that is mesorectal fat, which contains lymph nodes and lymphatic vessels. The T3 stage is determined by looking at this. Then there is a mesorectal fascia. Mesorectal fascia is this thin hypointense line which is surrounding the mesorectal fat, and its relevance is in CRM, circumferential resection margin. A positive CRM is a strong predictor for local recurrence and poor survival. Then there is anterior peritoneal reflection. This curved arrow represents the anterior peritoneal reflection. It is the hypointense line of peritoneum. It joins along the anterior wall of rectum in a curved fashion or V shape, which is a seagull sign. A tumor which involves this anterior peritoneal reflection is staged as T4A, and it includes the poor prognostic factor and also has an independent risk for intraperitoneal recurrence. Then this axial T2 weighted small FO images depict the rectal wall layers, and on the right side image we can see a tumor which is well confined within the rectal wall, and there is this peripheral dark T2 hypointense rim which is the intact muscularis propria, which depicts the stage as T2. Then as we have discussed previously, T1 and T2, T1 involve the mucosa and submucosa, and the T2 will involve muscle. MRI is not very sensitive in differentiating T1 from T2, except in some cases where there is a preserved hyperintensity or the bright signal of submucosa in some cases. So for this imaging, endorectal ultrasound is better. So for T3 lesions, there should be a discontinuity of muscularis layer, and the mesorectal fascia should be preserved. And as we have discussed previously, the distance between the outermost stage of the muscularis and the maximum extramural spread will determine the substages of T3 as A, B, C, and D, depending upon whether the tumor extension is 1 less than 1 millimeter, 1 to 5 millimeter, 5 to 15 millimeter, and more than 15 millimeter. And this small FOV axial images of the rectum shows eccentric wall thickening along the right lateral wall, and this as we can trace this hypointense muscularis. So the extent of the tumor which is outside this confines of the muscularis will determine this T3AB stage. Here it is very much limited, so it is AB. In this case, this is more extensive, so C and D accordingly. And one more pitfall in this imaging is we have to differentiate this extra mesorectal invasion from the desmoplastic reaction which occurs due to tumor infiltration into the mesorectum. So this spicules represent the desmoplastic reaction. These are T2 dark. These are not like bright, little bit bright or intermediate as this tumor, and it also has a nodular and white projection. So in this way we can distinguish tumoral extension from the desmoplastic reaction. Then coronal, oblique coronal small FO images. These are very important to look for the sphincter involvement. This is the internal sphincter. Internal sphincter is the continuation of circular layer of the rectum, and external is the continuation of the levator ani and puborectalis ring, and it has subcutaneous, superficial, and deep parts. The decision of low anterior resection with intersphincteric resection is done depending upon the involvement of the internal sphincter. That is, the internal and external sphincters are separated, and the internal sphincter is partially or completely removed depending upon the extent of involvement. Then this blue line represents the level of levator ani and the level of the ultra low anterior resection line. In this right lower images, we can see that the T2 intermediate, the tumor is extending beyond. This is the intersphincteric bright plane. This left side, this bright plane is obscured, and this tumor is involving the puborectalis. So this won't be a candidate for ultra low anterior resection. Then anterior peritoneal reflection. Anterior peritoneal reflection, it marks the junction of peritonalized and non-peritonalized portion of the rectum. As seen previously on axial, it looks like a V-shaped thin hypointense or dark band connecting the anterior wall of the rectum. And on sagittal, these are T2 sagittal images, it is seen as a thin hypointense line which is located between the rectum, this bladder and rectum, and it is just at the superior level of seminal vesicles. So anterior peritoneal reflection, it is seen on the imaging as the abatement of tumor. See, tumor is abating the reflection with associated thickening of the peritoneal reflection. This T4A stage, as discussed, is a risk for tumor seeding and intraperitoneal recurrence. Then CRM is the surface of the non-peritonalized part of rectum that is resected, hence it is relevant in mid and lower rectum, and the shortest distance between the outermost part of the tumor and the mesorectal fascia is measured. If it is less than 1 millimeter, it is positive. If it is 1 to 2 millimeter, it is threatened. Then extramural vascular involvement. It is an independent prognostic factor and a predictor of metastatic disease. It is seen as an extension of tumor into the vessels, which results in a wall irregularity, focal enlargement, and altered signal of the tumor within the vessels. Nodal staging, MRI is better for T staging than nodal staging, but factors which need to be reported are presence, number of precise location, proximity between the mesorectal fascia and lymph node, size, morphology, and mesorectal lymph nodes also need to be reported. The regional lymph nodes which are involved are mesorectal, superior rectal, medial rectal, inferior rectal, sigmoid mesenteric, inferior mesenteric, lateral sacral, presacral, sacral promontory, or internal ileum. Then nodal criteria. There are three morphological criteria which point out that the node is malignant. These are, one is irregular borders, one is heterogeneous signal intensity, and another is round shape. If a node is more than 9 millimeter in short axis dimension, we need not to look at this criteria. It is malignant. If the node is between 5 to 9 millimeter in size, then either two of these morphological characteristics need to be present, and if the node is less than 5 mm, all the three characteristics need to be present to say it is a malignant. Then restaging. MRI is also very helpful in restaging of the tumor. NICT is the standard treatment for locally aggressive cancer. So complete response is noted in 15 to 38%, and downstaging is seen in 50% of patients. So MRI is used to assess the tumor response. The normal rectal wall, which is adjacent to the tumor, can show some post chemoradio changes such as submucosal edema, that is thickened and high signal intensity. This can lead to confusion that this can be misinterpreted as a residual tumor. Some tumors may become atrophic or fibrotic. These variety of appearances we can grade on MRI. Generally, the residual tumor will show intermediate signal intensity and high signal intensity on diffusion weighted imaging. The fibrosis, post-treatment fibrosis will appear as a low signal intensity and on T2 weighted images as well as diffusion. Then the number of remaining suspicious nodes is important, and nodal size in the axis is more important than the morphology. Mucin response. There are three types of response after post-treatment. There is colloid degeneration as cellular mucin response, and mucinous tumor generally have a poor prognosis and a high chance of local recurrence. Then based upon the MRI morphological appearance, there is a grading, tumor regression grade of MRI starting from 1 to 5, in which 1 represents the complete radiological response, 2 represents good response with more than 75% fibrosis, 3 represent moderate response with more than 50% fibrosis or mucin, 4 slight response, and 5 no response. These are the axial T2 weighted small FOV images. The left upper images show focal wall thickening. These are the left side is a pre-treatment and right side is a post-treatment. There is a focal wall thickening along left lateral wall, and on post-treatment there is only T2 dark area, which suggests only fibrosis and complete response of the tumor. This right-sided images, these show a large mesorectal deposit which is hyperintense and intermediate on post-treatment, pre-treatment images, and on post-treatment there is significant reduction in the size of the deposit, and there is a dark area suggesting fibrosis with moderate response, giving it as a stage 2. These lower images suggest a wall thickening with a mesorectal extension nodular deposit. It on post treatment there is some moderate reduction in the size, but the tumor shows central dark area, that is the fibrotic area, and predominantly in the periphery it appears as intermediate to hyperintense, suggesting mild response and tumor regression stage 3. The upper panel of images such as pre-treatment and post-treatment images reveal that there is regression in size with predominant tumor. Post-treatment tumor shows the same signal intensity as the pre-treatment with only few dark areas, suggesting only small areas of fibrosis or small post-treatment changes with residual tumor. Then the lower set of images is represent the on post treatment MRI. The tumor signal intensity is fairly similar, suggesting no response, and giving it as a grade of 5, MRTRG 5. Thank you.
Hello. Good evening, sir. Can you hear me?
Yeah, Shankar, we can hear you well.
Yes, sir. Thank you. Today I'll be talking about total neoadjuvant therapy for carcinoma rectum. So the overview of my presentation will be like this. First, I'll talk about the definition. Why is there a need for total neoadjuvant therapy? Summary of evidences, the current NCCN guidelines for total neoadjuvant therapy, and finally conclusion. So TNT or total neoadjuvant therapy involves administration of both radiation as well as systemic therapy before surgical resection for locally advanced rectal cancer. So why do we need total neoadjuvant therapy? Because with the current standards of long course radiotherapy as well as short course preoperative radiotherapy, we have been able to achieve impressive local recurrence rates of as low as 5 to 10%. However, the 5-year distant relapse rate continues to be still high, around 30 to 35%. And also the patient complaints when it comes to delivering adjuvant systemic chemotherapy has been poor. Only 30% of the eligible patients even receive adjuvant chemotherapy, and of whom only less than 50% receive the full intended course of adjuvant chemotherapy. The main reasons include post-operative complications like leak, poor general conditions, slow recovery, or problems with stoma, or even outright refusal of treatment in the post-operative period. And it is a well-known fact that each 4-week delay in treatment correlates with a 14% drop in overall survival. So for all these reasons, it was thought, why not initiate the chemotherapy in the preoperative setting itself rather than subject it in the adjuvant setup. Another factor to be considered is pathological complete response rate. With current standard long course and as well short course radiotherapy, the pathological complete response rate is usually around the 10%, with some series with favorable results have reported up to 30%. We know that prognosis of such patients with pathological complete response is excellent. They have a 5-year survival rate of 70 to 80%. It is an independent surrogate marker for good oncological outcome. So the oncologists thought, why is there any way to improve the pathological complete response further? So new trials were initiated, and thus came in total neoadjuvant therapy. So neoadjuvant therapy was brought in with the intention of avoiding adjuvant chemotherapy, so that most of the patients can complete the intended systemic chemotherapy, and in some cases to even avoid surgery when pathological complete response could be avoided. And in those cases who eventually undergo surgery, there is also a possibility of early reversal of ileostomy, because there is often no need for adjuvant chemotherapy in patients who receive total neoadjuvant therapy. So total neoadjuvant therapy can be of two different types. It can be induction chemotherapy or consolidation chemotherapy. In induction chemotherapy, first chemotherapy is given, followed by radiotherapy and subsequently surgery. In consolidation chemotherapy, the patients are first subjected to radiotherapy, then subsequently consolidation chemotherapy, and finally surgery. When to choose induction chemotherapy or consolidation chemotherapy is once again a topic of debate. In patients who are likely to have higher metastatic risk are treated with induction chemotherapy first, and in those patients who have locally advanced lesions, consolidation chemotherapy is preferred. However, the general trend is to go more towards consolidation chemotherapy. So these are some of the important landmark RCTs related to total neoadjuvant therapy. I'll be giving a brief overview of some of the trials, summarizing the key findings of some of these trials, namely Prodigy trial, Rapido, Polish, and Opera trials. So Polish 2 study, it involved patients with clinical T3 or T4 lesions. Totally 515 patients were involved. The patients were randomized into two groups. One was the standard long course radiotherapy group, and the other was TNT group. In the TNT group, patients received short course radiotherapy followed by 3 cycles of FOLFOX. And subsequently, patients were subjected to surgery in both the arms after 12 weeks. The long-term results were published in 2019, and Polish 2 trial did not show any difference in overall survival, local failure, distant metastasis, and even grade 3 late complication rates between standard chemoradiotherapy and total neoadjuvant therapy. This trial failed to show any significant difference between the two arms. The Rapido trial, it involved randomizing patients with the clinical T4 lesion or N2 lesion, those with the positive circumferential resection margin or with extramural vascular invasion. Once again, patients were randomized into the standard long course radiotherapy arm or TNT arm. TNT arm once again contained short course radiotherapy followed by consolidation chemotherapy, but this time with either 6 cycles of Capox or 9 cycles of FOLFOX. And subsequently, both the arms, patients were subjected to TME, total mesorectal excision. The primary endpoint in Rapido trial was 3-year disease-related treatment failure, which was defined as either locoregional failure, distant metastasis, new primary tumor, or treatment-related death. Rapido trial was in favor of total neoadjuvant therapy. The 3-year disease-related treatment failure was much lower in the experimental arm, which was around 23% compared to 30% in the standard arm. And the probability of distant metastasis was also lower in the experimental arm, around 20% as opposed to 27% in the standard chemoradiotherapy arm. And overall pathological complete response rates were also once again in favor of TNT, with almost 28% achieving pathological complete response, while only about 14% were able to achieve pathological complete response in the standard arm. There was almost twice the PCR was achieved in almost 2 times the number of patients as in standard arm. The Prodigy 23 trial is another trial which compared TNT with standard chemoradiotherapy. Polish trial and Rapido trial utilized short course preoperative radiotherapy, but Prodigy trial long course radiotherapy was used. Here the patients with clinical T3 or T4 were randomized to standard long course radiotherapy or TNT arm. TNT arm involved induction chemotherapy with modified FOLFOXIRI followed by long course radiotherapy, and subsequently were subjected to total mesorectal excision, and there was an option of adjuvant chemotherapy in both the arms, in TNT as well as the standard arm. Here the primary endpoint was a disease-free survival, 3-year disease-free survival. This trial, TNT patients who received TNT had a better 3-year disease-free survival of 76% as compared to 69%. The 3-year metastasis-free survival was also higher in TNT arm compared to the standard long course chemoradiotherapy arm. It was almost 79% in the experimental arm compared to 72% in the standard arm. The pathological complete response was once again almost double as in standard arm, 28% against 12%. There was, however, no difference in quality of life or 3-year overall survival. The disease-free and metastasis-free survival was significantly better in the treatment arm. So, another question of whether induction chemotherapy or consolidation chemotherapy, which is better. To study that, another trial was conducted. That was OPERA trial, which included patients in stage 2 and stage 3 distal rectal cancers. In this case, the sequence was changed, and at the end of the total neoadjuvant therapy, patients were either subjected to operative management or wait and watch policy if there was a complete response clinically. The OPERA trial showed no difference in 5-year disease-free survival between the two arms. Both were around 70%. The 5-year disease-free survival rate was. The TME-free survival, that is the non-surgical approach, that was more commonly observed in patients who received consolidated chemotherapy, which was in about 54% as opposed to only 39% in the induction chemotherapy arm. And patients who were on the wait and watch policy, if they developed any tumor recurrence, they were subsequently subjected to total mesorectal excision. When they compared the survival outcomes between patients who underwent surgery straight away after TNT and those who recurred while on wait and watch, there was no significant difference in the disease-free survival, which shows that wait and watch is a reasonable approach in select patients with a complete clinical response and who can be subjected to close surveillance policy. There is a meta-analysis which compared the different studies of total neoadjuvant therapy, and overall conclusion was that TNT improves the pathological complete response rate as well as increased disease-free and overall survival. And in patients who receive consolidated chemotherapy, higher pathological complete response rate could be achieved, and thereby facilitating organ preservation, making it a viable option. So, to summarize, the benefits of TNT include improved pathological complete response rate, ability to treat micrometastasis at a very early stage, and helps in downsizing the tumor. It can help in assessing the chemosensitivity of the tumor, and also makes the patient compliance better compared to adjuvant delivering chemotherapy in the adjuvant setting. Also, watchful waiting is a reasonable option when complete clinical response is achieved. Also, in patients who undergo surgery after TNT, there is a possibility of earlier closure of stoma, which can potentially affect the quality of life. So, the current NCCN guidelines for CA rectum, patients with proficient MMR or microsatellite stable lesions, for T1 and T2 lesions with node positivity, or any T3 or any T4 lesion or locally unresectable lesions, total neoadjuvant therapy it can be tried, either induction or consolidated chemotherapy, after which restaging to be done. And then further treatment can be tailored according to the individual case. Either surgery or watch and wait policy can be tried. But in patients with deficient MMR, that is MSI high, immunotherapy is preferred. But these patients also total neoadjuvant therapy can be tried as in the usual setting. So to conclude, for most of the patients with locally advanced rectal cancer, TNT is becoming the standard of care, and it potentially helps to improve the pathological complete response rates, improve disease-free survival, decrease treatment-related failures, and more patients are able to successfully complete their chemotherapy regimen. Thank you.
Hello, can you hear? Is it slides? Hello, I'm Dr. Harish. Can you hear me now?
Yeah, we can hear you, but we can't see the slides. We can hear you, but can't see the slides. Regarding the neoadjuvant treatment, hello?
Hello?
Can you hear?
Hello, can you hear?
Yeah. So carry on.
Hello?
Yeah, we can hear you. See the slides also.
Can you hear?
Right now we can hear you, but no
Yeah.
slides.
Yeah. Can you see the slides now?
Yeah, it is there now.
Okay. None? Okay. So I'll be talking about anastomotic leads post low anterior resection. See, this anastomotic leak, it is one of the most, it's dreaded complication of any colorectal surgery. And of course, the patient has to go through a lot once anastomotic leak happens. It increases the perioperative mortality and morbidity. And we know that it's going to prolong the length of stay for the patient, and in turn he has to spend a lot of money from his pockets. And even after that, there's a chance that he may get readmitted again. Higher readmission rates are there. And generally, these leaks tend to go towards unintended permanent stomas. And of course, hospital stay and resources, everything is used up. So generally there are three grades which are classified. Grade A is one managed without an intervention. B is one which is managed with the intensive intervention other than repeat surgical intervention. That is, for example, a percutaneous drainage. Grade C are those which require repeat surgical intervention and often a diversion. Generally, we have in low anterior sections, anywhere between 6 to 30%. Different study shows 7 to 21%. So in this range itself, 6 to 30 to 30% is the general leak rate. And lower the anastomosis, higher the chance of leak is seen. And while the highest rate, 10 to 20%, was seen in coloanal anastomosis. So from ileocolic, colorectal to colonic anastomosis to rectal, the percentage goes on increasing. As it goes lower and lower, the percentage of leak also goes higher. So risk factors are the ones where the anastomosis is located within 6 to 8 centimeters of the anal verge, male, patient on steroids, pre-op chemotherapy and radiotherapy, hypotension, diabetes, smoking, obesity, malnutrition. These are generally tend to be the risk factors. So how do we identify? Generally, we look for classical peritoneal signs. If there is guarding, rigidity, tachycardia, tachypnea post-surgery, then more or less the diagnosis will be straightforward. But not always it will come in the classical peritoneal signs. So abnormal vitals, again, though they are not very reliable, that again points in the direction. And drain is again a good indicator. If fecal, it gets diagnostic, but not always. Sometimes you may get some dirty brown fluid, which may not be very clear, but it requires a higher suspicion of index of suspicion. So generally, presentations are they are diagnosed within the first 2 weeks of the surgery, and majority are diagnosed between 7th and 12th post-operative days, and 40% of the patient are also diagnosed after discharge, and 12% occur beyond the post-operative day 30. So there are different ways, the different time this anastomotic leaks can present. Early anastomotic leak is within 6th post-operative day. Generally, it is a technical failure of the anastomosis. Immediate anastomotic dehiscence is seen. And late anastomotic leaks are after the 6th post-op day. They tend to be poor healing process at the anastomotic site. Probably the blood supply is not adequate. They generally present with insidious and low-grade fever, prolonged ileus, and there is a lot of non-specific attributable symptoms which have to be picked up to say this is a late anastomotic leak. So how do we identify blood-wise C-reactive protein? This interesting thing here is it's observed about 48 hours after stimulation. It has got a better negative predictive value than a positive predictive value. If it is negative, we can clear-cut tell that chances of anastomotic leak are very low. But if it is positive, it could be the leak or it could be some other infection which is showing the higher levels of CRP. And procalcitonin has a shorter induction period, so it's within 4 to 12 hours of the insult, the procal raises. And meta-analysis shown that low procalcitonin on POD3 and 5 had high negative predictive values. The serial values, instead of an isolated level, they offer a potential for diagnosis than using a isolated single value. Computed CT with contrast enema. Here the contrast extravasation is seen, which is the most reliable sign, but as 15 to 17% it may not be present. And perianastomotic air fluid levels, if present, it is the next reliable sign after the contrast extravasation. Early postoperative CT for the first 4 days, fluid and inflammatory staining are nearly always present. So if there is no contrast extravasation or there is no air fluid level, sometimes it may be very difficult to tell on CT scan that clear-cut anastomotic leak is there. So management is with antibiotics, of course, but isolated antibiotics may not be of help. It has to be combined therapy, that is combination therapy of either more than one class of antibiotics is advisable. If there is a severe sepsis, always go for antifungal agents also. And then the question comes, what do we do if we find collection is there, and if the abscess more than 3 centimeters size is there, percutaneous drainage option, because the success rate are good up to 85%, and until the cavity size closes to the size of the drain has to be left in place. And generally this is preferable in patients who are hemodynamically stable and there is no signs of diffuse peritonitis. Of course, if there's peritonitis, we are going to intervene immediately. And successful intervention drainage significantly lowers the mortality rate compared to the medical treatment alone. Like I said, there's no point in adding only antibiotics and leaving the cavity inside there. So antibiotics along with some procedure will give a better outcome. Then, of course, the source control, that is remove the source of focus of infection and prevent any further contamination. And then we have to restore the anatomic and physiologic function. Earlier the intervention, better the outcome and lower the mortality, and it should be initiated within first 12 hours after the diagnosis. So what do we do? There are two ways, that is anastomotic salvage or anastomotic takedown. Takedown of anastomosis results in 2.5-fold increase in rate of permanent fecal diversion and the chance of higher permanent stoma. Whereas anastomotic salvage with the loop diversion, usually it is preferred in low pelvic anastomosis. Statistically fewer post-operative death, recurrent sepsis, reoperation, permanent stomas than anastomotic takedown. So it's quite obvious that where possible, better not to take down the anastomosis. Salvaging the anastomosis is far better than taking down the anastomosis. So effectively, we'll be doing a stoma for most of these cases. That is, protective stoma will reduce the incidence of clinical leakage. though it is not associated with decreased mortality. Mortality rate can be there, but then clinical leakage chances are definitely reduced. In one of the meta-analyses, the presence of protective stoma effectively decreased the incidence of anastomotic leakage and reoperation, and is recommended in patients undergoing low rectal anterior resection for rectal cancers. So with this background, we'll just look at two videos now. This is the first video where ultra-low anterior section, the anvil, and it's coming inside now. So this is immediate intervention, what we can do. See, now we are fixing it. It's gone up to that orange mark and it's fit well. Now it's getting approximated. You see what happened there near the arrow? There is a small diastase there. It just gave way. Sometimes the stapler just gives way, probably because of more pressure, or the stapler might be a bit old, or it may not work properly. See what we have done here. Completed the firing. Now you can see the opening there. You see they're pushing the saline from below betadine and it is coming inside through that. The anastomotic site is approximated with PDS. So once it is completely secure, a diversion stoma is done. Here again the air leak test is being done. See, the air is passing inside now and there is no leak. So this case immediately stoma was done. It was recognized intraoperatively itself. Definitely requires a stoma. Generally, post chemoradiotherapy, usually it is stoma is preferred if you are going for ultra low anterior section. See, the donut is incomplete. This is another video where 2 weeks later patient came with peritonitis. So went in laparoscopy. So many interloop additions, so much of pus is there, diffuse peritonitis. Again, there was a question, no, what to do, if whether to take down or whether to salvage. Where possible, it is better to salvage. See, so much of pus cavity is there. Completely, we are taking down loop by loop. These kind of cases, when we do laparoscopically, we have to take our own time and make sure that you give thorough wash. Every loop has to be cleaned. Use a lot of saline to clean up. Leave multiple drains inside. all interloop collections, additions. It's 2 weeks since the surgery, so he came with all clinical signs of peritonitis. See, so much of pus is there in the pelvis. If you can identify the site of the perforation, you can just take a bite. Anyway, we are going to do the diversion for these patients, if it's accessible. But if it's not accessible, you're not able to identify, no problem. Leave multiple drains with a diversion stoma. Like I said, you don't have to take down the anastomosis. You can just leave the drain inside, diversion, and you can wait for the patient to recover. Thank you.
Hello.
Yes, sir.
Yeah. In which conditions you think of Hartmann procedure rather than the diversion alone with the drains?
Hartmann's most of the time we don't do, sir, because most of the time we prefer loop ileostomy itself. It's easier to reverse.
Suppose if the colon that has been anastomosed is been become ischemic.
Yes,
then,
you can take.
Yeah,
Yes, yes, yes. You
those
have
cases,
to.
those
That is
cases,
the last option. Yes, yes. If there is no viable blood supply is not there, disconnect that thing. Get it as an end stoma.
So as far as possible, as you say, try to avoid it, because then it requires another major surgery to reconnect it, and
Definitely.
most of the patients end up with a permanent stoma.
Yes. Most of these late cases who come, they tend to have this anastomosis, blood supply, some kind of compromise will be there. So if the complete necrosis or blood supply is compromised, you can disconnect and get it out, because low anterior section, again going and anastomosing below all those things, it's practically not possible. So best would be to put a diversion and colostomy and wait for him to recover.
After the anastomosis, do you do anything to minimize the risk of leak after the anastomosis? Once the anastomosis is made, do you routinely do anything?
No, nothing in particular. We check the air leak test is done during the anastomosis itself, and if air leak test is not there, we don't do nothing. We don't have to do anything. If the mainly when you're transacting the mesorectum, if you are not bared the mesorectum and applied the stapler properly, and most of the time it works well. And if it's very low, of course, post chemotherapy, radiotherapy, and all, it is better to go for stoma.
It is actually well known that intraoperative flexible sigmoidoscopy, by doing that, you can see the anastomotic bleeds, as well as if there is a leak, you can easily, if it is approachable, you can do it. Do you use ICG?
ICG, no, sir.
the-
Most of the time we don't use. No, most of the time we don't use ICG. Like you said, what we do is on the third post-op day, we do a CT with a rectal contrast to see if any contrast extravasation is there. Sometimes we do prefer sigmoidoscopy. On table, we generally don't do sigmoidoscopy, because sometimes it may take some time for the compromised blood supply to show up. So first we do CT with the rectal contrast, and after that, if requires, we put a sigmoidoscopy and check for them.
Okay, thank you very much. Thanks. Great presentation. Well done.
Thank you.
Thank you.
Thank you, sir.
Hello, Dr. Bhavanta.
Yeah, Dr.
Yeah,
Hello.
we can see you.
Dr. Rakesh.
Yeah.
Yeah, I've removed the specimen. I think somebody can show the specimen. One of you open the specimen and see the lower limit. Can you show? I will myself. I will show before put the stapler, everything. So I'm just removed. I have just introduced the anvil inside. We have made a end to side actually. Keep that. So meanwhile, bring the specimen. We'll show the specimen. இங்க இருக்குதா? அங்க இது இதுக்கு இங்க இருக்கு. அவங்களுக்கு தனியா வச்சுக்கோ. அவருக்கு கொடுக்க வேண்டியது. இது அவருக்குள்ள கொடுக்கணும். இதை எடுத்து அதுல வச்சுக்கலாம்ல நம்ம இதுல. Come this side and show, man. Light இங்க கொடுங்க. Tooth for sister. Sister கொடு.
சாருக்கு ஒரு 7 கிலோ வருது. ஓபன் பண்ணி இருந்தது பாரு கிலோ.
இந்த பக்கம் போடு. இங்க போடு. நான் டூத் ஃபோர்ஸ் அதை கொடு.
டூத்ல கொடு.
இங்க சார்.
என்னது இருக்குங்களா அது கொடுக்க வேண்டியது.
நான் நல்லா ப்ரிப்பேர் பண்ணல பவல். So not fully prepared bowel. So I said no yesterday. The scope is not going beyond. So the preparation is not adequate. So are you seeing that? I am cutting the. So it's a very hard tumor.
Yeah. Maybe post-radiation effect also.
இது பின் இது சாமி. This is the tumor edge.
Okay. A doctor said. I don't. Yeah.
Okay. So you have enough clearance. Oh, you have very good clearance. So this is the. So this is the tumor lower edge. Can you see? So we have
we can
more
appreciate
than,
that.
Yeah. So we have enough clearance. Okay.
Yeah, very good margin.
So more than 3-4 centimeter we have given clearance. Okay.
Yeah.
That's great.
Can you appreciate? Okay.
Yeah, well done.
Yeah, take a. So I have put the anvil inside. So we are going to for end to side actually. So I am just using the 29 circular stapler.
Are you planning to?
So I didn't. I have done a full splenic flexor mobilization. Hope you people have seen or not. I don't know. Maybe after that we can see.
Yeah, we saw.
Sorry.
Are you going to defunction with ileostomy here?
Yes, definitely.
Definitely. Okay.
For this case, definitely. இதை காமிச்சிட்டு இதை காமி ரெண்டையும் நல்லா புடி. இது லிகாஸ்டர் கூட லிகாஸ்டர் ஹார்மோனிக் கூட இல்லாட்டினா அல்ல ஹார்மோனிக் தான் நல்லது. There was a nice bleeding from the cut end. So we need not bother about the blood supply of the proximal colon. Kuduma. பிடிச்சுக்கோ.
1 minute பாருங்க. அங்க இருக்கு தருவா.
இந்த பக்கத்துல காமி. கொடு கொடு கொடு. அந்த வேற எது வாங்கிக்கணும். சரி. இந்த பக்கம் நீ படி. நல்லா இருக்கு. பிபி அதிகமா இருக்கு. எது தொட்ட முடியல வருது.
138 சொன்னா.
Dr. Ajubandem?
Hey, yes.
Yeah, you are using 29.
Yeah, 29. Yes, I'm using 29. Ethicon, yes.
You always go for end-to-end or?
No, always end to side.
End to side.
So I have put the anvil.
Okay.
Just so you can. I'm just closing the proximal stomach colon end.
That you can staple it, no?
Yeah, after stapling, just for hemostatic stitch, I'm just.
Okay.
Because too much bleed is coming.
Okay.
So extensive blood supply. So
vascularity is well maintained.
So well perfused.
If the length, if you feel is not sufficient, do you go for end-to-end or otherwise also?
Sorry?
If the end, the length of the colon. If you
no, we have done enough full, so you can see
not
it is going
case.
more than 5 cm beyond the suprapubic.
Not in this case. If the length is not, if you feel it is little bit compromised, there will going to be tension at the anastomosis. Do you go for end-to-end or in those cases also?
Yeah, usually in all my cases, I will do the splenic flexor mobilization. But
So
still,
that
I
is,
would go for end to side only. Probably will not give like 5 to 6 centimeter. Instead of immediately, I'll go like just 1 to 2 centimeter only.
mm.
பிடிச்சுக்க.
We have done a financial incision.
Yes, I have made a financial incision. We always make a financial incision.
And any criteria like to say that the length of the tip of this colon should if it comes to pelvis from outside, it
Yeah,
goes.
yeah. That's why I said if say we more than beyond the if it's more than 5 centimeter beyond the pubic symphysis, then it
Yeah,
is
then
okay.
it should easily reach.
Yeah. Good. ನಾನು ಕೊಡು. பேப்கா கொடுத்துக்கிட்டே இரு. ஏன் பேப்கா கொடு, அடுத்து என்ன பண்றேன்னு பாருங்க. பேப்கா கொடு, அது அப்புறம் பண்ணோம். சக்ஷன் போடுமா? ம் பேப்கா கொடு. கை இருக்கு. எங்கேயோ வேற பேர் கொடு, வேற பேர் கொடு. கேஸ் ஆன் பண்ணு, கேஸ் ஆன். லேப் செக்ஷன் போடு. இன்னொரு 5 mm கொடுத்துரு. ஹெட் டவுன் பண்ணுமா. ஹெட் டவுன். மாப் கொடு, மாப் கொடு. பேட் கொடு, க்ளீன் கொடு. அதை கொடு ஃபர்ஸ்ட். ஃபிக்ஸ் பண்ணதுல ஃபைம் கொடு, ஃபைம் கொடு, ட்ரொக்கார் கொடு, ஃபைம் ட்ரொக்கார் கொடு.
டாப் லைட் ஆஃப் பண்ணிக்கங்க.
பவுல் ஹோல்டிங் கொடு, லாங் பவுல் ஹோல்டிங் ஃபர்ஸ்ட் ஃபேன் பெட் ட்ராக்டர் கொடு. இப்போ இதுல இதை காண பாரு, கேப் போயிடுச்சு பாரு.
லாங் பவுல் ஹோல்டிங் சரி நாங்க
இது கேப் பாருமா, இது எங்கேயுமே போச்சு, வாசல் போயிடுச்சு.
சார் வாசர்
இந்த தரேன் சார், இந்த போட்டு விடுறதுல லாங் பவுல்
ரொட்டீன் பவுல் ஹோல்டிங் கொடு.
அம்மா அச்சன் மாத்திடுங்கம்மா.
ஹெட் டவுன் பண்ணிக்கோங்க நல்லா, அப்படியே பிடிச்சிக்கோ. ஹெட் டன் லெஃப்ட் அப் கொஞ்சம் பண்ணிக்கோ, சக்ஷன். ஓகே. சக் 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 இரிகேஷன் ஆன் பண்ணிருக்கா?
இரிகேஷன்
லெஃப்ட் காங்க வெஸ்ட்.
இரிகேஷன் ஆன் பண்ணுங்க.
ஆமாம், காமிச்சிட்டு தான் இருக்காங்க. ஸ்டூல் போடு. So the perineal surgeon is introducing. So while introducing, you have to lift the bladder.
How many centimeters from the anal opening? Verge?
So around 2.5 to 3 centimeter only from anal verge. So just to accommodate the head of the stapler. Wait pannu. Okay. Okay. So only thing we have to separate this muscle. Hold this, man. So it do not include the muscle. Okay. Okay. Can you see this? Yes. இன்னும் கொஞ்சம் push பண்ணு. Little bit. Push. Okay. Come out. இன்னும் கொஞ்சம் push பண்ணு. கொஞ்சம் கீழே பாரு. Okay. கீழே பாரு. Okay. Okay, open. Yes. He is opening the stapler to open the spike. Okay, come out, no problem. Make it fast. Okay. Yes. அப்படியே இருந்துக்கோ. சக். பிடிச்சி.
For any twist or anything there.
Yeah. That's why I'm looking. But usually nothing will be there. If it lying like this, it is okay. So end to side like this. So there is no any twist. Okay. அதில் போட்டு எடுத்துட்டு வர நோட்டு. You have anvil forces, sir. Anvil forces. Wait. Come out. Come. Right down, right down camera. இதில் ஒன்று போட்டு ஆக்சுவலாக இதை பண்ணிருக்கணும். இரு. Come out. Click sound இருந்துச்சு. Go here and show. Yes.
Lock.
Yes, lock. Come out. Close. Yes. Come here. Come here. Nera come. Left up. Left. Okay, come out. So yes, close the stapler. So it,
Yeah.
after docking, he has closed. So full tight as should come. Okay.
Wait for some time.
Yeah, usually I'll wait for 30 seconds. Because while closing slowly, you have to close. So fully, there will be a marker which has to go beyond that midline. கொஞ்சம் head up பண்ணிக்கோங்க. Suck. போதும். round வேண்டாம்.
One gauze piece you had kept
Sorry?
there.
I have removed that gauze piece.
One gauze piece.
So before I remove the gauze piece, just I want to show the sphenic flexion mobilization. Somebody was asking, unless you do the sphenic flexion mobilization, it will not reach the anal canal. Okay. Whole inferior border of the pancreas has been divided off. Okay. Suck. Okay. Time ஆயிடுச்சா? Okay, you can fire. My head up கொஞ்சம் பண்ணிக்கோங்க. லைட்டா. சரி, okay, fire. Okay.
Do you do a leak
Yes,
test?
definitely.
How do you do with a sigmoidoscope?
No. Air leak test only. I have put a saline inside. Suck. Put air and see. Any purpose.
Air with what?
To look, put some air through the rectum. Yes, from below. Suck. Hey. Okay. So head up பண்ணிக்கோங்க. full 2 rotation இல்ல, இன்னொரு half rotation பண்ணு. Head up. Okay. இன்னொரு half rotation பண்ணு. Okay. Remove. Yeah, he is removing like a fistile movement.
The thread you can take it out. It should have been cut now.
அது எடுக்கிற வரைக்கும் பிடிக்கணும். ஹெட் அப் இன்னும் கொஞ்சம் பண்ணிக்கோ. சரி. Clean. தள்ளி தள்ளி வச்சு போதும் கரெக்ட் அப்படியே போதும் ரொம்ப அழுத்த வேணாம், சும்மா கொடு. அதை மட்டும் எடுத்து. So you can see the downnet. This is the distal and the proximal.
Yeah.
Okay, the integrity is good.
Very good.
So we will go for a leak test. Oh. Already it looks very aerated. Huh? Okay, put some air. No, it's not going properly. Here, பண்ணிட்டு பண்ணு. Okay. எடுத்துட்டு பக்கமா வச்சு பண்ணு. டேபிள் வந்து நல்லா இல்ல. டேபிள் ஹைட் இன்க்ரீஸ் பண்ணுங்க. வெயிட். Okay, do. Oh, okay. பட் ஃபுல்லா இதா இருக்கு. நீ வெளியே வச்சு பண்ணிட்டு சக். சக். இன்னொரு போடுறியா? இப்போ போடு. பிஆர் பண்ணிட்டியா? இப்போ போடு. சும்மா வெளியே டிப்லேயே வச்சுக்கிட்டு போடு. இன்னும் கொஞ்சம் உள்ள தள்ளி போடு. ஃபாஸ்ட்டாக ஒரே ஒரு அழுத்தத்து. ஓகே. But not much of air could be. So it's very low. Okay. Anyway, there is no obvious bubbles there. Okay. So anyway, we are going to do ileostomy. Okay. Thank you, Dr. Bhavanta.
Thank you very much for great demonstration.
Thank you for moderating. Dr. Varghese, Dr. Balu, Dr. Roshan, Dr. Pradeep Sharma, and Dr. Anil. I think I don't know how many of they must have left. Sorry for this prolonged
No, that's
surgery.
perfectly all right. It was great demonstration, and we really enjoyed
I
it.
hope all the delegates enjoy the workshop. We'll see next month. Okay.
Great.
Thank you very much.
Thank you.
Thank you, Doctor.
Yes.
Okay,
You
good
want
night,
to tell?
Thank you, Dr. Rajesh.
Okay. Good night.
Thank you, Dr. Rajabandiyam, for demonstrating an extremely difficult case.
So
Thank
nice
you
for
very
the
much.
moderator.
And thank you.
At least
Thank
while
you.
I'm concentrating on the surgery.
Dr. Bhavanta.
Okay. Thank you, Dr.
Okay.
Rajesh.
Okay. Thank you very much.
Well done. Good night.
Yeah.
Thank you
very
for
much.
all those seeing this video live workshop. Thank you. Head up கொஞ்சம் பண்ணுங்க. Okay, you can cut man. இது கூட DT எடுத்து கூட கொஞ்சம் head up பண்ணு.